revenue of 3 fractionated products only is $20 million US. That's the worth. Obviously, no doubt that it's a multi-billion industry. It has a lot of potential. And we are sitting on that potential. Okay. Provided we are able to, we will be able to harvest or harness this potential if we are able to do certain things. That is, if we are able to establish a national blood system, which obviously requires a lot of medical competencies which span so many fields. They must all operate under local physical, social, political, financial conditions. And obviously, to summarize, that would need an interactive set of strategies. What again it would mean is that people at all levels, all tiers, all sectors have to be very creative. Think about it. Make your own solutions and then try to do something about it. It won't be that you just import the solution, you have your own circumstances. But obviously, keeping in view the principles, no compromise on the principles. Example, that's the population of Turkey. And their budget is 100 billion US dollars, equating 2.8 trillion rupees, just to give you a perspective and impression. So when we started off in 1947, what we had? We had 3 centers in public sector and 1 in military. Punjab had the best of the organizational structure when they had an Institute of Blood Transfusion, which was managing the public sector hospitals and transfusion services. They had a capacity building diploma program there, but it did not keep pace with the time. It deteriorated. It did not take the, it didn't come up to the developmental challenges they were there, both for the quality as well as the population growth. So what we ended up over the time was total fragmentation of blood transfusion services. All sectors involved in that sectors included public sector, the military sector, the non-governmental sector, and NGOs, this private sector as well, which over the time had become a significant player. So because we didn't have the regulation, the private sector also grew up randomly, and there was no, you can say, protection of customers, consumers, patients' rights. So it was a demand-driven, no work, no organized structure. That was the situation until we embarked upon, and obviously a lot of contribution towards prevalence of transfusion-transmitted infections. Over the time, when we started off with this journey, which we talked about all day long, I'm not going to dwell on that. So we came to the point that we had the legislation. We made progress. We had the legislation in all the provinces, including AJK and GB. We had the establishment of the regulatory authorities. And we had, with the help of German government, developed the structures of regional blood centers across Pakistan. We know that. And they upgraded the hospitals as well. How much annual donations we are collecting? Not a very precise data. But when I, somewhere back in 2010 or 12, was trying to collect the data, so I had found a shortcut and I said, okay, I will look at the import data of blood bags in the country. And at that time, it was used to be quoted as 1.2 million, but actually the blood bag import data showed that we were collecting 2.4 million. I think this is one of the best ways to actually document how many bloods we are collecting. But nevertheless, as Dr. Sabha says, it's around 3 to 3.2 million. It is across, this data is from Dr. Hassan's report, which was submitted in 2017 to WHO, and it says about around 580 banks are collecting, according to them, 2.4 to 2.5 million blood. And of these, we are making components in less than 30%. 20% components are being made. So the volume of wasted plasma world over, mainly low middle income countries, is around 5 to 6 million liters 10 years ago. And it is around 9.3 million liters of recovered plasma annually. And we are contributing about 0.3 to 0.4 million wastage of plasma to this volume, total volume. We know this data over the time. The regional blood centers that are either being run in a public sector or in a private-public partnership, they are sitting on a total volume of around 0.6 million donations. They are collecting 0.6 million donations. And if 6 donations recovered plasma are taken together, that constitutes 1 liter of plasma. So that means straightforward that from 14 of these centers, we are collecting about 0.1 million plasma, potentially that is there. Because they're making components, they are screening at least with CLIA, and they have an information management system. They have a good structure, well planned. So that is what I call a low-hanging fruit. So if you translate this low-hanging fruit into what it is, like 0.3 million grams of IVIG, 0.9 million grams of, that's a total potential. About 10 million international unit of factor 8, and about 0.084 million grams of albumin. If you look into and extrapolate that, if you were to salvage whole of the plasma, that is the countrywide potential. What we need to do? We need to make a business plan or a program that would make sense to the policy people, that would make sense for the people who are delivering service, and that makes a lot of sense for the people whom we want to facilitate, our patients, and develop our self-sufficiency in these products, which are definitely safer and better products. So what it means is that if we are able to mobilize investment in the recovered plasma, starting from this low-hanging fruit of 0.6 million donations, some additional investment, that would mean, for the covering up the deficiencies in GMP compliance. Obviously, the fractionators and people are not going to come unless we have a plasma which is GMP compliant. So if we are able to bring in the investor, may it be a private sector, may it be a public sector, may it be a government to government, maybe it's the international partners, whoever. So you mobilize this recovered plasma, then you will generate revenue from there, and a reinvestment that in safety, so that you can generate more of the plasma volume. So self-sufficiency as per our national needs with contract manufacturing, obviously that is the phase we need to go through, and it'll be long time before we should be thinking about a plasma fractionation plant. That would mean maybe we have a good GMP compliant recovered plasma as well as source plasma of the tune of 0.4 million at least liters per annum. Then it would probably make sense. Simultaneously or sequentially invest in source plasma as a long sustainable solution to that. So that's how it can work if consistently, persistently, what we do this. We have our private companies, the industry, the professional societies, think tank, whatever. They need to do advocacy, constant engagement, advising the policymakers, investors, service providers, making plans, and investing in infrastructure and whatever is required, the brain behind it, the lobbying behind it, the advocacy behind it, so that we don't lose track. The government facilitation, no doubt, would be required to have a sensible national blood policy, which we are revisiting, because the last was made during Dr. Hassan's period in Safe Blood Transfusion Program. So after that, this was due. So the new policy has been sent, the draft has been sent, and it addresses sufficiently, because at that time, probably we were beginning and we did not address that sufficiently enough. So we are addressing it here. Legislation, regulation, rules, resources, national blood program coordination, everything that a policy making people and the governance tools that are required need to be done. Because it's very important that if the plasma has to go out of the country, the regulator have to have the capacity. And the best way would be to make a benchmark saying that our regulators should get compliant or follow and become, using this WHO global benchmark tool plus to build the capacity. They need to make rules, obviously, monitoring, improving, and regulatory coordination is required. Because in our country, we have not declared, or the blood transfusion activity doesn't come under DRAP. So what you need to do is there should be a close coordination. And the blood establishment, the service providers must focus on GMP compliance, whatever it takes. Obviously, they have to have resources, but the resources need to come if the government has the appetite and the will and the capacity to actually do it itself or ask other people to do it. So once that is done, that's the part, that's a busy figure, but it's a very important one. It's a part of the policy. It lays out the relationship of different entities. The one in the black are the tools that the government need to use. The ones in the squares are the institutions, the organization, the physical, presence of those departments, governmental and other ancillary. So the safe blood transfusion has to be revived. It has to be the coordinated activity. Center doesn't have the volumes. It's the provinces that have the volume. And after 18th Amendment, we have decentralized devaluation of the power has happened. So they need a lot of coordination. Somebody should be, this is the in the center, National Technical and Advisory Committee, the think tank. The think tank need to provide the technical documentation. Obviously, these are the regulators. The provincial, national program, regulation of these, and obviously there have to be, whoever is sitting on the plasma need to come into the fold. We have the tragedy that we are shifting 1 million blood annually, volunteer blood mostly, to the thalassemia. And we know the quality of life they enjoy, they die in their teenage, mostly. So that's the sort of how these are linked. Then what we need to do is, how do we handle the DRAP as well? So what is suggested here is that these regional blood centers should be declared biological source material collection facilities. So if you have GMP compliance and you have a license from the regulator who has the capacity to call it a biological source material collection facility, and then DRAP should agree to it, that these are the centers who are collecting APIs, and that active pharmacological ingredients have to be exported for contract manufacturing, either through private-public partnership or private entities or industry or whoever. So these are the places, and we already have, fortunately, these structures who have come up in the form of 15 regional blood centers. So they should upgrade simultaneously or sequentially into source plasma programs with investment. So once we need to register these. We need to register blood donor organization. We need to make it a, unethical, medically wasteful practice if we want these NGOs to share the resources with the regional blood centers. They should not be wasting their plasma and platelets coming from the volunteers. As I said, 0.8 to 1 million, that's a huge sum. So they should not be doing that, and somebody should make sure. And obviously they have to be linked. I know this can go on, obviously, and it can, over the time, wean off, and those places who have the volume should be declared as centers in the private sector who meet certain conditions. at least equal to the public sector regional blood centers which have been equipped. Okay, what about the broad plasma plan? I said that's a part of policy as well. It says that if you have the coordination mechanism in place, you have declared these as your biological source material collection facilities, which DRAB should find okay. You get the investors, you get other ministries and departments facilitated by the government to look at and smooth out the things. And then you have procurement of plasma, both source as well as this. And these companies should bring back the PDMPs against the plasma and provide it free of charge to where the patients are. Not only that, they should be the one who should be investing in GMP compliance to begin with. And I would propose, important, that the plasma should be obtained per liter cost, and that cost should be credited to the government in a separate account, which should be used to upgrade the district and tehsil and rest of the blood banks, and further continuing, so that you have the resource. You have the resource to invest in quality. So if you have this kind of program, we need to build the regulatory capacity, because without regulation, our plasma obviously have to be GMP compliant to be acceptable to the fractionators in any form, whether it's a contract or whatever later is to become. So that's the benchmark. The regulators need to be trained, and this is what the global benchmark tool plus is for the capacity of the regulator. That has, maturity levels have been defined, as is shown here. And where are we? Somewhere here. Lot of hard work for the regulator to upgrade its capacity to the level. So there has to be a political will and commitment if we are to have we have to carry forward this program. Because otherwise, the plasma may not be accepted, especially speaking what you have seen in the morning, the epidemiology of the diseases that we are having. We have 6%, 5% TTIs in Sindh reported, around 3 to 4% somewhere in northern part of the country, mostly hepatitis C in the southern part. In northern parts, you have almost same. Emerging epidemic of HIV, no doubt about it. The percentages that epidemiologically we are telling people is enough to discourage the people who should come in the plasma fractionation. So that would mean that probably you need to, that's again, depending upon what sort of contract is taken by the, whoever the private or public or whoever the investors are, that how do they look at the epidemiology? They might think that we need to do NAT. If that is what the thought is, then they need more investment. But nevertheless, it's a bad epidemiology. It is even worse than the low middle income countries quoted by WHO in their recent 2021 data. Even worse than that. Okay, so how do that do? That's a first step approach. The first step is we need to have a will that we want to go there. Once you want to go there, then you have to take all the pain and steps and continuously. With the help of PAP and PSH, I said we are going to run a program in November in Lahore so that we invite the regulators and introduce this concept so that we start working towards that. This is what is recommended by WHO. So the regulator is so important that unless you have a capacity of the national regulator, we will not be able to do this thing. Okay, that's taking the hypothesis forward. Plasma fractionation means to improve the blood transfusion system. Yes, by all means. Agreed. It is to be done. It can be done, and it is the way forward. If you have a program, and as I said, that will and continuous effort coordinated towards that, and this is all the detail, what you need to, what they are going to ask for, the GMP compliance. This is all detail. Everybody knows that. They can look into the documents that, you have to comply with these things. So the phase 0 would be that we don't have a national blood system, there's insufficient quality of plasma, and then you have to probably, we've fortunately passed this. And now we are somewhere here, where we have a potentially sufficient quantity but low quality plasma, which is available. We have incomplete organization of fragmented system, which precludes the uniform standards and quality. Regulatory capacity is very weak. So we have to complete the reform. No second thought about it. Obviously, the discussion the morning was that can be, with the international partners, whether it's the government of Germany, which has cooperated so far, we need to go again with some plan and request, and WHO, involve the WHO because of this, and then explore investment GMP compliance of potential supplier of domestic recovered plasma. So phase 2 would be, we meet the quality and we have a more quantity. Then we initiate the program for recovered plasma, contract fractionation, produce more plasma for fractionation simultaneously from a source plasma, and decrease the quantity of imported PDMPs, rely on cells. And then phase 3 would be when you have sufficient plasma that you think of fractionation plant. It's not easy. Even if the people who are willing to, invest in money, it's the capacity. If you look at the Brazilian experience, it's a wonderful paper if somebody wants to go through that. What problems they faced, although they did had a primitive sort of 3 fractionation plant, old type running with them, but still the challenge was the capacity, the engineering capacity, the rest of the capacities, and way around the legislation. That would be another question, because when you run the source plasma, when the country has not even reached more than 10% of volunteer blood donation, and we are saying in our legislation that you got to be a volunteer, how do you think we are going to get people for source plasma? There has to be some other thinking. I suggested one time, because lately in European Union, they have revisited their legislation and they've allowed remuneration, but obviously certain capping as well as qualification of that remuneration. They had to do it in order to get the plasma. Canada did it. They are remunerating their donors. So you need to either create a provision or have some other creative solution. And Iran would be another place where we can look into. They allowed the source plasma in the private sector. They tried it in the public sector, and they found out that the whole blood donations went down from volunteers. So they stopped it. They said that we are going to do something in the future, either as a concurrent plasma program or something else. So we are, that's where we stand. So we can move forward, and as I listed, how we can go about that as a plan. So that's from our national poet, Allama Iqbal. That's the translation. Dil so se khali hai, nigah paak nahi hai, fir isme ajab kya कि तू बेबाक नहीं है. So what it implies is you have to have a passion. If you don't have the passion, you would not see the clarity and the spark which is required. I thank you all for your very patient listening.
Thank you, Dr. Nuzhat, for such a great talk. And it was really a great piece of information for all of us, as it is a new topic, I guess, for most of us.
Would you like to have questions
Any
now?
comments from our chairs?
I must appreciate, and this was according to my expectations, very well presented, a comprehensive note of information for all of us. But for me, I have a little comment and a little question as well. Comment is this, that the cost which you reflect during your presentation, I actually did assessment here at provincial level last year when we were going for that plasma fractionation project. And it is quite high than what you have presented in your presentation, because, more than 50% has been paid out of pocket by relatives of those patients, which was not into my loop. Rest was again, from the public sector hospitals, which they are utilizing in terms of albumin, IVIGs, and clotting factors. But that is again quite huge cost. So I think for us, this should be a lesson learned, and we all should collectively work on this project very honestly. We should pour in our suggestions, our thoughts to the policy level to bring this project forward. But with that, there's a little query regarding what you are going to include in that national policy guideline about that breakup of, like, we have to keep in loop the DRAP, we have to keep in loop the health sector, we have to keep in loop the defense ministry and other ministry in terms of customs and import and export thing. So what do you think? Are we able to bring in loop all of them together with a good coordination mechanism, and that also in very near future? Because as we are thinking of and we are planning to have this project very soon. So what do you think about that?
Thank you for that question and a comment. It's a strange thing that spending 33 years in military in a very small confined space, now I'm a public person and looking at a very big picture. First of all, madam, had a political will, we would have probably placed a technical expert at safe blood transfusion program. Okay. So maybe you can somehow on our behalf lobby that get the right person to do the job. WHO says what? It says that if you can't have the right person as a national coordinator, forget about reform in the blood transfusion. That is its words. So if you are not going to get the right person for the job, we should forget about what we are going to do. Okay, so that will be my first submission. Secondly, if you look at the draft policy, which I recently wrote as well as made it public out of desperation so that I can get a lot of comments and criticism, because I have not been, as I said, I think there should be a lot of weaknesses in that, although both the diagrams were what I proposed as a coordination mechanisms. So I propose to make a think tank. Altruistic reasons के लिए लोग experts इकट्ठे हों, and they keep on engaged with the government, irrespective of what the government is, what the time is, who is there. They should be there as an advisory capacity. They should be doing the expert's job. That will be my second recommendation. The third recommendation would be to make a sensible business program onto that and try to bring as many stakeholders who are concerned with that. Tackling of the DRAB, I've already suggested, if your regulator is a good coordinator and DRAB accepts that Sindh Blood Transfusion Authority, etc., is competent enough to license a person for GMP compliance or license a blood establishment for a GMP compliance, DRAB should accept it. And the PDMPs can be imported with the same private setup which has procuring the plasma and providing it to the public sector. Yes, they can get registered with the DRAP. So the DRAP doesn't need to jump again if they trust the other regulator. So that's how you are going to do it. So the coordination for that project, maybe the Safe Blood Transfusion Program can have a special interest group within its ambient, which works exclusively for this thing, and aggressively does all that and make sense and coordinate and plan and ask people and bring your on board, and and create a win-win situation for everyone. As long as we have a fragmented blood banking system, which was there and which was coordinated, as long as the people remain fragmented, you'll not be able to do the project of that scale. So what is going on right now is a fragmented activity. Every now and then somehow I get the information. It's all fragmented. Who is working where? you just suddenly are surprised that you have another player, a different player, governmental player, private public partner, and whatnot. So unless you get together, it won't work. Nobody can do it alone. So that is my, key message. And if somebody can convey that those messages, the right one, fortunately we are with that, finally got engaged. Look at the national blood policy. Tell me if there is something more that can be helpful. I try to be very prescriptive and explicit in that, which doesn't need to be if it is a policy, but I thought that probably if we spell out who has to do what, then maybe it can make a difference.
Thank you. We have another question from our co-chair.
Excellent presentation, and you have highlighted in a very complete manner the need of the hour in transfusion practice revitalizing in Pakistan. My comment is that we need carbon copies of Dr. Bari. Just get the carbon copies and do it with someone so that the technical expert would have some backing from the at national level, some backing from the resource providers, so that we can in Quran it is written that we have made the human beings at asani takveem. We have not even explored the 5% of plasma potential. PRP, fibrin glue, there are so many other things. We are just at a very, very low level of getting albumin or immunoglobulins. So let's join hands and make it not baby steps. We are already 70 years old, so we should take giant steps towards this goal. Thank you very much for enlightening us.
Thank you for your comment. But people have been talking. I was also talking to Dr. Khurshid, and we said that it's a UK model, and that model and that model. Why not emulate the USA model, which says that you outsource the service to a non-governmental organization and let's regulate them. So when we have the regulatory capacity with that, so why not say, okay, let the Red Crescent or Indus or whoever do it all for the country? They have the experience. That's the shortest route, if you ask me. Build the regulatory capacity, outsource it to a credible organization. That's it.
Thank you, Dr. Nusrat. We have another comment from our honorable guest, Dr. Hassan. Please.
Thank you very much. WHO has a special scheme or a project for building the capacity of the countries who are interested in working in the plasma fractionation sector. And this scheme is working very well in Indonesia and also in Senegal. And there's no reason why it can't work in Pakistan also. But in order to have this actually happen on ground, the government needs to make a request to WHO. And so far, it has not occurred to them to do so.
Private organization is not.
Thank you, honorable guest and Dr. Nuzhat. So we are moving towards our next talk. Our next speaker is Dr. Yuyun Wayuningsi. She's online with us. Dr. Yuyun is team lead for blood and other products of human origin at WHO headquarters in Geneva, Switzerland, for technical standard and other specifications of human and health products policy and standards department. She has received IPFA award in the recognition of her exceptional contribution in the safe blood transfusion and for increasing access to plasma-derived products, especially in low and middle income countries. She has served as director of the Central Blood Transfusion Services at the Indonesian Red Cross, regional director of the International Society of Blood Transfusion for Southeast Asian region. So we will proceed with her talk of the International Society of Blood Transfusion for Southeast Asian region. So we will proceed with her talk of the International Society of East Asian region. So we will proceed with her talk of the International.
Here are the
So we will proceed with her talk.
here are the
So we will proceed.
are the
Please be patient. There is some technical issue, and we are going to have her online.
So while waiting for the slides, I just would like to welcome all the participants to this meeting, and I also would like to thank on behalf of WHO that already invited me to share some information from WHO. Meeting in person, but I really enjoy all the presentations since beginning. Thank you. Meeting in person, but I really enjoy all the presentations since beginning. Thank you. Meeting in person, but I really enjoy all the presentations. All the presentations.
We have pre-recorded talk of Dr. Yuyun. We are proceeding with that talk.
Here are the outline of my talk. So first is the background. Plasma-derived medicinal products as essential medicine. Here are the challenges of my talk. So first is the background in low to middle plasma-derived medicinal products as essential. Here are the challenges of my talk. So first is the background. Medicinal products as essential medicine. Challenges of lack availability of PDMPs in low to middle income countries. WHO responses to the challenges of lack availability. Challenges of lack availability of PDMPs in low to challenges of lack availability of PDMPs in low to challenges of lack availability of PDMPs in low to challenges of lack availability, WHO responses to the challenges, WHO guidance on increasing access to PDMPs in low-to-middle-income countries, WHO project to assist member states Here are the outline.
Dr. Yuyun, are you with us?
My talk. So first is the background. Plasma-derived medicinal products as essential medicine, challenges of lack availability of PDMPs in low to middle income countries, WHO responses to the challenges, WHO guidance on increasing access to PDMPs in low to middle income countries, WHO project to assist member states and clubs. WHO has designated blood products such as whole blood, blood component, and plasma-derived medicinal products as essential medicines because blood transfusion can save lives and patients around the world depend on transfusions and plasma products every day to keep them healthy. However, blood products carry inherent biological hazards and process-related hazards that can lead to serious or fatal consequences. Therefore, it is essential that blood is only used when clinically needed, so mean that when the patient condition can only be improved by blood component transfusion and when alternative therapies are not available and when the administration of the transfusion can be properly monitored. So for example, the patient may need the red blood cell transfusion or platelet concentrate transfusion. So this mechanism or this practice promotes the production of blood components and causes plasma that is not used for transfusion to be wasted. The data showed that approximately 9 million liters of plasma from low and middle income countries were discarded. To promote the use of plasma for PDMP's productions, plasma-derived medicinal products has already been included into the WHO list of essential medicine. And recently, in 2023, the pathogen-reduced cryoprecipitate has also been included into the EML. So you can see the document of the World Health Organization model list of essential medicine, which has just been published in June 2023 through the web link that I provided in this slide. And from the table, you can see that the cryoprecipitate pathogen reduced as well as the cryoprecipitate non-pathogen reduced has already been included into this essential medicine. Although WHO has included the PDMPs into essential medicinal list, the Global Report on Blood Safety 2021 showed that there are at least 6 main challenges which is interconnected each other in blood services. The first challenge is inadequacy in policy, financing, and governance, insufficient supply of blood, deficiencies in safety, effectiveness, and quality, and lack of availability of PDMPs for a long time is known and deplored in most of low to middle income countries. Other challenges are suboptimal clinical practices and poor access to blood during emergency situations. Lack of availability of PDMPs is supported by the data come from 162 countries. 55 countries reported that plasma collected domestically was used for the manufacturing of PDMPs, either through local productions or contract productions, or just sold the plasma for productions. And only 45 countries provided the data on the volume of plasma that were delivered for PDMPs manufacturing, as shown by the table below. 91 countries reported that PDMPs were imported, and while 16 countries reported that no PDMPs were used during the reporting period. The table showed you that there were around 18 million liters of plasma provided by 45 countries for production into PDMPs. And in Africa, Americas, and Southeast Asia regions, most of this plasma were recovered plasma. But this data is not included the plasma collected by commercial apheresis center. This slide shows you the global distribution of factor VIII use. As you can see from the left-hand side figure, that Africa, Southeast Asia, and Eastern Mediterranean regions, which are home for more than 60% of global population, they could only access around 11% of the globally available factor VIII. Furthermore, this slide shows you that the high and upper middle income countries, representing 34% of world population, consumes around 91% of total factor VIII in 2020. Reasons of lack of availability of PDMPs in limits are insufficient plasma volume. This can be caused by the use of whole blood for transfusion rather than use the blood component. And then the plasma quality may be also not meet the fractionation standard because the blood center may not aware of the GMP standard that should be achieved, and then lack of technology for fractionation. And as you know that only a few plasma fractionators are available in Asia and Africa. So in Africa currently there is only one plasma fractionator in South Africa. In Southeast Asia, there are several fractionators in India, South Korea, and Thailand. And in Western Pacific, there are several fractionators in China, Australia, and Japan. However, not all fractionators have experience running contract plasma fractionation and transfer technology. And again, establishment of a local plasma fractionator requires high investment. So what is the WHO response into these situations? WHO strategies in health sector are directed by the WHA resolutions. At least there are 4 World Health Assembly resolutions currently drive the WHO strategy in blood. The first resolution is on availability of safe and quality blood components and plasma-derived medicinal products, which aims of achieving self-sufficiency of blood products. The second resolution is on the regulatory system strengthening, aims of achieving at least maturity level 3 of the regulatory system, including the regulatory system for blood. And then the third resolution is on global action on patient safety, aims to promote patient safety. And the last resolution is on strengthening diagnostic capacity, aims to establish regulation, assessment, and management of diagnostics. Last year, World Health Assembly requested the WHO to continue to report to the Health Assembly every 2 years until 2023 on progress made in the implementation of resolutions on availability, safety, and quality of blood products. Strategies to implement WHO resolutions related to blood. First is on the self-sufficiency of blood products. So activities to support this strategy is to ensure adequate availability of blood products, including during emergency situation, ensure the quality and safety of blood products. And then the second strategy is to achieve the blood regulatory system strengthening into maturity level 3. The activities to support this strategy is that the blood policies, regulation, and standards should be in place, and the global benchmarking tool on medicine should be run in parallel with the global benchmarking tool plus blood. And then there is also important for the country to appoint the NRA to oversee the blood products. The third strategy is promotion of patient safety through put in practice the clinical use of blood in patient blood management, and also to build and implement the hemovigilance system, and of course also to increase the access to PDMPs. And then the fourth strategy is regulation, assessment, and management of diagnostic, in which the medical devices and IVDs used for blood services and transfusion should be controlled. Several activities to support strategy to ensure adequate availability of blood products are achievement of 100% voluntary non-remunerated donation for blood and plasma, change of hospital-based donation to community-based donation, especially for hospital-based blood center, processing whole blood into blood components, so there will be enough volume of plasma for production of PDMPs. Donor counseling system should also be in place. Adequate funding for all activities related to blood donation. So for this mechanism of funding, actually WHO has already established the guidance on costing of blood services, in which this guidance shows you the activity-based costing. So the funding should be allocated for each activity, for blood or plasma donor recruitment, for blood and plasma collection, blood processing, blood and plasma testing, as well as for the blood plasma storage and distribution. So the capital cost and recurrent cost should be allocated for each of these activities. And a blood supply network also need to be built, so there will be sufficient blood component during the emergency situations, and a plasma apheresis donation system should be wisely developed. And lastly, the activity on centralization of blood testing and processing is believed can standardize the quality of blood component, and storage and distribution can also be centralized to reach the effective blood services. All strategies mentioned should be stated in the national blood policy, regulation, and standard. Strategies to ensure quality and safety of blood products are that a standard of GMP for blood establishment should be available, and if the country has not yet established their national GMP standard, then actually the country can use the WHO guideline on good manufacturing practices for blood establishment, established in 2011, or other internationally recognized standards such as 2021 PICS Good Practice Guidelines for Blood Establishment and Hospital Blood Bank. And also, I think the country should develop the regular GMP inspection, usually done by the Food and Drug Administration Agency, and then conduct the training on GMP implementation for both GMP inspectors as well as for the blood establishment staff. And at the blood establishment, the quality manager and quality control trained person should be available, and also they should have adequate funding to implement and maintain the GMP standard. GMP assessment from a foreign regulator where plasma fractionators is located can be done if the country decided to run the contract plasma fractionation, and then implement technology to improve the quality and safety of blood can also ensure the quality and safety of blood products. There are several technologies to improve quality and safety of blood products, such as using the sample separated blood collection bag, and then collecting the blood component using the apheresis technology, use the local depletion system, either by using the bottom-up bag or using the local filtered bag, and then implement the pathogen reduced technology that can inactivate RNA or DNA of the pathogen. And maybe for certain patients, the blood center also should implement the irradiated technology for blood component. And of course, the temperatures during transportation should be monitored. In this slide, the table showed you the available commercial pathogen reduced technology from some commercial companies. Strategies to strengthen blood regulatory system are establishing a nationally well-coordinated blood services that consists of a specific unit at the Ministry of Health to establish and monitor the implementation of blood regulatory systems that regulates the blood center, the hospital blood bank, plasma apheresis center, as well as regulate the blood transfusion chain activities. And there should be also a national blood center that can build the strategies and plans to implement all the blood regulations. And it is advised to also establish a cluster blood center to run centralization of testing and processing of blood coming from the satellite or customer blood centers. So the blood component quality can be standardized at national level. And the hospital blood banks that prepare the blood for transfusion, so including the storage, cross-matching, test, and distribution is another element of the national blood services. Appointment of the authority that oversees the quality of blood product is also important. So usually in many countries, this role handled by the Food and Drug Administration Agency. Financial sustainability, and again, should be guaranteed, whether it comes from the government, from the recovery cost of blood, as well as from the PDMP's production later on if the country decided to start producing the PDMP. And decision that blood products are essential medicine is again the important or essential component to support the or to strengthen the blood regulatory system, and implementation of global benchmarking tool plus blood, which is a tool to assess the blood regulatory framework by the FDA in parallel with the GPT for medicine. Further strategy is the promotion of patient safety by implementation of clinical use of blood and patient blood management practices, and also increase the access to PDMPs. So as you know, that clinicians and other health personnel play a key role in ensuring safe blood and safe transfusion, so they can run the monitoring of the storage and transportation of blood component, subscribe blood transfusion only if there are no alternatives for the patient, use blood components appropriately and based on clinical indication, monitor transfusion adverse reaction through hemovigilance system, and manage transfusion reaction properly. Establishment of the hospital blood transfusion committee is again another element which is necessary to be built, because this committee can discuss about the adverse reaction on transfusion, so they further can prevent reoccurring of the adverse reaction. Patient blood management practices. So I think the PBM consists of three pillars. So the first pillar is detection and management of anemia and iron deficiency. The second pillar is minimization of blood loss and optimization of coagulation. And then the last pillar is leveraging and optimizing patient-specific physiological tolerance of anemia. Another strategy is that the clinician have a big influence on the utilization of PDMPs for treatment. So the demand for PDMPs will drive the production of safe plasma protein products, and the use of PDMPs will decrease the demand for transfusion in long term, and the use of PDMPs will drive the implementation of GMP by blood establishment. So in this slide, I also place some WHO guidance that can be used by the country for put in practice the clinical use of blood, and then also for building the hemovigilance system, as well as for building the policy on the patient blood management. The strategy on regulation, assessment, and management of diagnostic can be supported by building the regulation on medical devices, in vitro diagnosis, and other consumables used for blood services. So there also, the monitoring system for implementation of the regulation should be in place. So for example, the country should build the registration procedure for medical devices and IVDs, the licensing system for medical devices and IVDs, as well as developing a list of approved medical device and IVDs used for blood services. And the last component of this strategy is establishment of a national control laboratory. So this laboratory can function as to run the pre and post-market evaluation, the calibration of national panel using WHO international standard, and also running the national external quality assessment scheme. In this slide, I would like to further describe about the WHO strategy specifically to increase access to PDMPs. In February 2020, WHO has established the action framework to advance universal access to safe, effective, and quality-assured blood products, which aims at strategic direction to global efforts to address present barriers to safe blood. One of the mandate of this action framework is to develop the guidance on increasing supplies of PDMPs in limits through fractionation of domestic plasma. So this guidance has already been established in 2021, and you can access this guidance through the web link that I provided in this slide. In the guidance, I would like to further describe about the capacity building and decision-making steps of plasma fractionation program to improve availability of PDMPs made from domestically produced plasma. So at first step, the country need to assess the local clinical needs. So for example, this assessment can be supported by the data on how the clinician diagnose the patient, the data of the amount of products required, and then what kind of plasma products of interest, and also is there any consensus clinical guidelines. And then the second step is to assess the status of blood and plasma collection system. So the country need to see whether there is a national blood program, and then is there any blood or plasma collection procedures at national level, and also is the blood establishment already compliance with the GMP standard. The next step is to assess the status of the national regulatory system. So for example, is the quality and safety requirements in place? Is there any site inspection procedures? And also, is there any product license procedure? So last step is to build or to run the plasma fractionation when the country consider that the plasma volume at national level is sufficient. So however, to start this plasma fractionation, of course, the country should consider the economic situations, and then also should consider the selection of technological approaches and product to be manufactured, and also the regulatory measures should be in place. Another important information which is consists in the guidance is the stepwise approach to improve the supply of PDMPs at national level. So phase one, if there is insufficient volume of recovered plasma for fractionation at national level, then the country still depend on the imported plasma-derived medicinal products. But in this phase, actually, the country also can start to think about preparing pathogen-reduced plasma protein fractions using validated technologies preserving product efficacy, so the patient can get safer protein products. And then phase two, when the country has enough recovered plasma volume and also the recovered plasma meet the quality, and the establishment has an auditable qualified system based on current GMP, and also when the blood and blood component demand is being fully satisfied, then the country can start to estimate the need for PDMPs and initiate a program for fractionation of recovered plasma, for example, by running the contract plasma fractionation program, and produce more plasma for fractionation by apheresis mechanism, including getting the concurrent plasma and source plasma to meet stepwise clinical demand of PDMPs. And then in this phase, then the country can start to decrease the quantity of imported PDMPs. Phase 3 is when the volume of plasma for fractionation produced at national level is sufficient, then the country can consider a national or regional facility for fractionation. However, for the PDMPs that not yet produced domestically, then this product can still be imported. To assist member states to improve quality of blood for transfusion and plasma for fractionation, in 2009, WHO has run the Achilles project in South Africa and Indonesia. In South Africa, this project resulted in appointing the National Bioproduct Institute to run the plasma fractionation for South Africa and currently also run the plasma contract fractionation for Namibia. And in Indonesia, the project resulted in strengthening the blood regulatory framework. So since September 2022, WHO and ISPT have been engaged in a collaboration and cooperative activities to advance access to safe plasma protein products in LIMICs in alignment with the WHO Achilles project up to August 2027. So in this slide, I show you the collaboration agreement document, and also if you are interested, then you can also access the document of the Achilles project in 2009. To get more support from the stakeholders to run this project, ISBT hosts the International Coalition for Safe Plasma Proteins. So the funding to run this project can be provided by the ICSPP members as well as from the other resources through ISBT. The current members of the ICSPP are the ISBT, the International Organization for Blood Donation, the World Federation of Hemophilia, the International Patient Organization for Primary Immunodeficiencies, International Plasma and Fractionation Association, and Plasma Protein Therapeutic Association. Activities of the project are situational analysis, and based on the situation in the country, the project can help to strengthen the elements of national blood system, including the competent national authorities with appropriate regulation, the blood establishment, healthcare institutions, hospital blood banks, blood donor organization, relevant patient advocacy group, or other relevant parties. And then the production of safe plasma protein products can be run by utilize the recovered plasma for production of safe plasma protein product, or by approaching the technologies of production of safe PPP, such as running the small-scale production of PR cryoprecipitate and IVIG, or running the plasma contract fractionation, or establish the local plasma fractionation, if feasible and cost-efficient, through technology transfer from plasma fractionator. And of course, other activity appropriate means to achieve the aim and goals of the WHO and ICSP. This slide shows you the available pathogen reduce technology in the market. For example, the Intercept platform from Cerus, they use the amotosalen followed by illumination, while the Mirasol platform from Terumo, they use the riboflavin followed by UV light, and the Teraflex system from Mycopharma, they use the methylene blue. So these three technologies can be applied for mini pool of cryoprecipitate. Another available technology in the market is the cryo SDF platform from VIPS, in which this platform can be applied for more unit of cryoprecipitate. So in this slide, I would like to further explain a little bit about the SDF pathogen reduce technology from VIPS that currently run in Dakar National Blood Center under the WHO ICSPP pilot project. This technology can be applied into the pool of 30 to 35 native dry cryos, and then into this pooled cryoprecipitate, we can add the solvent detergent that can reduce the pathogen, and then add the oil to remove the solvent detergent, and then the free solvent detergent cryo product can be passed through the absorption filter. Then the sterilized the cryoprecipitate can be divided into smaller portion. So by using this technology, finally we can standardize the content of the factor 8 in each small bag of cryoprecipitate. I will not explain about the plasma contract fractionation as well as establishment of the national plasma fractionator because I think these two topics will be explained later on by other speaker. So just to close my presentation, I can say that the PDMPs have been included into WHO model list of essential medicines, and access to PDMPs is highly insufficient, especially in low to middle income countries. WHO strategies to increase access to PDMPs was directed by the World Health Assembly resolutions. World Health Assembly Resolution 63.12, established in 2010, implementation should be reported up to 2030, and the member states should focus on ensuring availability, quality, and safety of blood products through the implementation of GMP standard, as well as also put in practice the centralization of blood testing and processing to standardize the quality of blood products. Seeking government commitment through the establishment of a robust blood regulatory framework is another important focus, and then promotion of patient safety through the implementation of clinical use of blood, patient blood management, and the pharmacovigilance system is also important. And lastly, the focus should be on seeking the government commitment on the control of medical device and also the in vitro diagnostic use for blood services. And plasma protein production will in parallel improve the quality and safety of blood for transfusion. I think that is the end of my presentation, so thank you for your attention.
Thank you, Dr. Yuyun, for your amazing speech and enlightening us with your great experience. Dr. Durinaz and Dr. Aisha, do you have any comments? Are we connected with her? Excuse me. Yeah, she is with us. Please open the Zoom over here. Yeah.
Yeah, I think it is there. Dr. Yuyun, Dr. Durinaz Jamal here. We definitely miss your physical presence here, Yuyun. But on the other hand, we appreciate for sharing in that lot of information with us and for the valuable time you have given for such a good forum. With that, I'll only say that we look forward to having guidance and good technical support from WHO when we are going to start this project here in Pakistan very soon, hopefully. Thank you.
Thank you very much, Dr. Saab. Thank you. Inshallah, we'll start soon.
Inshallah.
Inshallah.
Do we have any questions from our delegates? Thank you, Dr. Yuyun. Now we are proceeding towards our last talk of the session. I would like to introduce distinguished Professor Dr. Thierry Burnoff. He is Vice Dean of the College of Biomedical Engineering at Taipei Medical University, Secretary Global Blood Safety Working Party ISBT, and Steering Committee member, International Coalition for Safe Plasma Proteins. He is Director of R&D and Plasma Fractionation in France. He has been closely involved in the development and industrial implementation of new plasma fractionation and virus inactivation technologies for developing economies. Dr. Burnoff has published over 250 articles and book chapters related to plasma fractionation and blood products. So I invite Dr. Thierry for his enlightening presentation. He is also here online with us. I welcome you, Dr. Thierry. Am I audible to you, Dr. Bernoff? Can you please unmute yourself, Dr. Theri? Dr. Bernoff, can you please say something so that we can check if you are audible?
Yes, I am there, but my presentation is recorded.
Yeah.
Yeah, thank you.
Okay, we are proceeding with your pre-recorded
Okay,
talk. Okay,
thank you very much. Thank you. Yes, first of all, I wish to thank the organizing committee for
So he will be with us for live Q&A, and right now we are proceeding with the talk.
asking me to share some elements of information that can be taken into consideration when seeking to improve the access to safe plasma proteins, and in particular in low and middle income countries. As you know, the horizon cannot be reached, but in this field, the goal is to strive to ensuring that high quality, safe, affordable, and equitable therapies are readily available to all patients in need of plasma proteins nationally and globally. What I will try to do today, in line with recent WHO guidance, is to describe some complementary stepwise options which can be considered in order to gradually improve the supply of safe plasma proteins. So these complementary options are described here. Of course, one consists in registering and importing plasma products which are licensed in other countries, so import of product. But I will also describe technologies which can be made possible to prepare local, small-scale, pathogen-reduced cryoprecipitate or immunoglobulins. So in a short words, pathogen-reduced plasma, pathogen-reduced cryoprecipitate, and small-pool immunoglobulins. Then you can reach a stage where contract plasma fractionation can be considered. And when it is justified, consider the construction, the design, construction, and development of industrial domestic plasma fractionation facilities. So these are the various options which can be considered. And obviously, the three listed here are a means to provide some strategic independence in the supply of safe plasma proteins. So, some time ago, in September 2020, the Working Party of Global Blood Safety organized an online workshop where different approaches were described. And one important element which came out from this workshop is the importance of taking into consideration the annual volume of plasma which can be generated in a country or at a regional level, because depending upon this level of plasma, different approaches can be considered in order to move towards reaching the horizon. So it was considered that when the volume of plasma is less than 50,000 liters per year, this number can, to some extent, be discussed because it depends on the some plasma fractionators, but when this volume is less than 50,000 liters, it was considered that small-scale mini-pool production of pathogen-reduced protein is one way to prime the system in the right direction, because it allowed to provide safe plasma protein for patients who otherwise are not treated or treated with unsafe, crude, non-pathogen reduced plasma fraction, like is currently the case for fresh frozen plasma or cryoprecipitate. Then when the annual volume of plasma is reaching 50,000 liters and potentially up to a level of 250,000, 300,000 liters, then the option of contract fractionation completely makes sense. And when a country is capable to generate at least 300,000 liters of plasma or more, then the question of building domestic plasma fractionation can be discussed and decided. So these are these two options: contract fractionation with an established plasma fractionator located abroad, or constructing a domestic facility is the way to provide what is considered to be the state-of-the-art industrial scale plasma-derived therapy, which are subjected to a different step of pathogen reduction or viral inactivation and removal steps, and which are ways to ensure some level or a good level of strategic independence. Regardless of the approach, the stepwise approach which can be followed, I think it's very important to have in mind that anyway, overall regulatory requirements for the blood establishment or BE must be followed in order to prepare plasma donation for further processing, which in this presentation will be abbreviated like PFP. So there are several elements which should be considered when looking at the regulation of the quality and safety of plasma for further processing. The blood establishment producing this plasma should implement uniform good manufacturing practices. The plasma for further processing should be, the blood establishment producing this plasma should be licensed and inspected by the national regulatory authorities of the country. These blood establishments should be audited by the entity which is going to process the plasma by the three approaches which I described in the previous slide. And it is also important to perform a risk assessment of the quality and safety of the plasma donations based on the processing technology which will be used to make safe plasma proteins. So here I put just some example of elements or criteria to make sure that the plasma for further processing meet quality and safety requirements. So there should be good donor screening and demonstrating their eligibility to provide plasma which can be used to make safe plasma protein using these criteria. There should be good documentation and traceability, as you can read here. The equipment which is used to collect the blood and process and obtain the plasma should also be validated for its intended use and regularly calibrated. And there should be a periodic and rigorous quality control testing to ensure that these plasma can meet the requirement for the preparation of the safe plasma proteins. Other elements of quality and safety are shown here. The staff involved into the preparation of these plasma should be properly trained. There should be a good management of the cold chain, because this is quite important to maintain the quality of the plasma protein. There should be regular internal and external audits to ensure GMP compliance, and corrective and preventative actions should be made following an established system to identify and correct any deviations from established protocol and to prevent future deviation. So again, this is the basic, this is the foundation, this is the background, regardless of the type of approaches which will be implemented to produce safe plasma proteins. So now let's go into a bit more details and look at what can be done when the volume of plasma generated by blood establishment in a given countries reach a volume which is less than 50,000 liters per year. So this is where pathogen reduction and mini-pool processing can be considered, and this is something which has been described again in the recent WHO guidance, and ourselves within the Global Blood Safety Working Party of ISBT, we are putting substantial efforts to explain the rationale of this approach. So this is what I just mentioned. It is described in the recent WHO guidance. So to promote initial stepwise approaches for improving the supply of safe plasma protein in low and middle income countries. So the basis is to strengthen the GMP in blood establishment. It can be considered to conduct quarantine or retest the plasma, which will be used for transfusion or for the production of cryoprecipitate. So in order to eliminate donation, which would have been collecting during the window periods for the viral markers. It can be considered to implement validated pathogen reduction technology of plasma and cryoprecipitate. And one additional step is to look at the potential to make mini pool or small scale domestic processing of virus inactivated cryoprecipitate and immunoglobulins. So as you are certainly well aware, in terms of producing plasma which is pathogen reduced, there are three technologies which have been licensed in several countries. They are all based on a photochemical treatment of single plasma units or small pool of 2 or 3 plasma donation. So using a technology based on the psoralen and UVA treatment, which is developed by Ceres. A technology using riboflavin and UVB developed by Terumo, and the methylene blue and light treatment developed by Mako Pharma. So this allows to get pathogen-reduced plasma, which can improve the safety of the transfusion of fresh frozen plasma. Of course, the plasma which is subjected to the pathogen or photochemical treatment can be subjected to cryoprecipitate, and this allows to get a cryopoor plasma which is pathogen reduced and which can be used for a safer treatment of people having deficiencies in the number of coagulation factors, as you can see here, or ADAMS 13. And from this cryoprecipitation step, you get a cryoprecipitate, pathogen reduced, which can be used to for patients with bleeding disorder associated with acquired or deficiency in factor VIII, fibrinogen, Wilbon factor, or factor 13. There is also a technology developed by VIBS in Switzerland based on a method which has been developed and implemented in Egypt. So in this situation, the plasma which is collected is not subjected to pathogen reduction, but will undergo a cryoprecipitation step, allowing to get cryoprecipitate here, as well as cryopoor plasma. These cryoprecipitate the donation can be pooled together, about 30 to 35 cryo donation can be pooled together, and then subjected in a bag system to a treatment by solvent detergent, followed by oil to remove these compounds, and followed by filtration. So this allows to get mini pool cryoprecipitate subjected to a dedicated value inactivation treatment. And the same with the cryopoor plasma, and using the bag system, you can pool several plasma donations together and perform a caprylic acid treatment, which is a known process allowing to purify the immunoglobulin and at the same time inactivate lipid-enveloped viruses, followed by dialysis and filtration and allowing to get a fraction, which is pathogen-reduced immunoglobulins. So this is a few details concerning this mini pool cryo PR in the bag system. You can see here a picture of the medical device as it is provided. You can find a number of details on this technology in this publication. And here you have a drawing of the bag system where you have a bag where you you put the cryoprecipitate, you perform the solvent detergent treatment, you do oil extraction to remove most of the chemicals, so TNBP and Triton X45, followed by a charcoal filtration to remove the residual amount of the solvent and detergent. Filtration system on 0.2 micron pooling, and then you can dispense this pathogen-reduced cryoprecipitate into several bags, which can be frozen and provided to the hospital. So here you can see the detail, a bit more details on the processing, and so you see a volume of about 450 ml per mini pool, which allows at the end and in this system to prepare more than 3,000 units of factor rate, getting more than 10 milligrams of fibrinogen. You get virulent factor as well as factor 13. This mini pool process can be also applied in different ways to prepare pathogen-reduced immunoglobulin with caprylic acid purification, caprylic acid virus inactivation, a concentration step, and a sterile filtration, and you get a product which can reach a concentration of about 50 milligrams of immunoglobulin per ml. This shows you some detail about the bag system with here the caprylic acid. You have here the different combination of bags which allows to prepare the immunoglobulin, and the same principle is used. The final product can be sterile filtered and dispensed into bags for transfusion. There is another approach which has been developed in Pakistan, in Karachi, at the university, where they prepare pathogen-reduced immunoglobulin from COVID-19 convalescent plasma. They use a technique of caprylic acid as well, so a bit similar, or actually quite close to the one developed in Egypt for a mini pool bag system, and several publications on this technology have been published. It's possible to consider a stepwise improvement on the quality of the immunoglobulin produced by this caprylic acid technology. One is to consider ion or anion exchange chromatography, which will be able to remove IgA and IgM, because caprylic acid co-purified IgA and IgM together with IgG. And in this type of system, these IgA and IgM can be bound on the chromatography column, while the IgG are going in the flow-through and are therefore depleted of the IgA and IgM. Nanofiltration can also be considered, in particular if IgA and IgA are removed, and you can consider to use a nanofilter with a pore size of 1920 nanometers, which will allow to get dedicated removal of non-envelope and additional inactivation or removal, I should say, of envelope viruses on these small nanopore size filter. And here, transfer of technology or assistance from suppliers can be sought. So what are the advantages of such local mini pool processing? So I think it's a good means, or we think it is a good means to improve the access at national level to safe plasma protein when plasma-derived medicinal product, PDMP, made at industrial scale and subjected to purification step and at least 2 virus reduction treatment, when these products are not available or available in insufficient quantity to treat patients. This mini pool processing can be implemented on small yearly volume of plasma, and this technology requires minimal capital investment. We believe it's a valuable learning and training phase on GMP in blood establishment to prepare plasma for further processing. It's also good training for understanding what is meant in plasma processing, and this technology at small scale can still be very compatible with the phase where the country consider industrial contract or domestic fractionation, because not every product, in particular fibrinogen or some hyperimmune globulin, cannot be obtained through industrial contract fractionation, or even when you have a domestic fractionation facility. Obviously, this approach avoids, and this is important, the wastage of plasma. And as we said, it contributes to education in GMP, in blood establishment. And since there are already countries understanding how to perform these technology, it is amenable to south-to-south sharing of experience and a search in finding context-specific solution to access PDMPs. So now we move to the next step when the volume of plasma is more, when you can get 50 to 250,000 liters of plasma per year, then contract plasma fractionation can be considered. So what is contract plasma fractionation? I again to look at the WHO guidance, and it is defined as an arrangement in which domestic plasma is provided to a fractionator, which is licensed in a foreign country, and the PDMPs are provided in return according to predetermined terms for use within the country. So you see, it's a relatively wide definition on what can be done for contract plasma fractionation. In practical terms, though, the country which is collecting the plasma get this plasma. There is a central warehouse where it can be stored at temperature which are typically less than minus 30 degrees. It is transported abroad where it is fractionated by this plasma fractionator, and then the product come back to the country which has been collected the plasma. It can be used in hospital or provided to pharmacy for home treatments. We should keep in mind that there are several ways to conduct contract plasma fractionation systems. So there are several possible forms of contractual arrangement which can be considered. So how it is achieved? Again, it's important to understand the important elements for success. Government support is important for legal aspects, regulatory, financial aspects, potentially the authorization to export temporarily the plasma. There should be support from blood donor organizations, patients organizations, and local clinicians who need to understand the value of going through a contract plasma fractionation in order to get access to more product and maybe other type of product which can be well suited for the patients. There should be sufficient volume of quality plasma on a on several years to come, at least 5 years. GMP collection of plasma should meet quality specifications, so through auditing and inspection. As we said before, authorization to export the plasma so that products can come back later on. The national regulatory of the country collecting the plasma should perform auditing and licensing of the plasma fractionator. The products coming back should be registered in the plasma supplying countries, and I think it is very important to have a transparent process with public support and understanding. So the parties which are involved to conduct the regulatory oversight include the national regulatory authority of the country collecting the plasma and the one of the plasma fractionator, and there should be a good dialogue, good understanding between these two national regulatory authorities, and it is also a very important educational process. People need to speak the same language when it comes to understand the importance of the quality of the plasma for fractionation and the quality and safety criteria of the PDMPs obtained by this type of arrangement. And there should be also a good understanding, sharing of the same goals by the plasma supplier and the plasma fractionator, because the plasma fractionator will need to conduct audit to see how the plasma is collected, and the plasma supplier should also go and visit and audit the plasma fractionator to make sure that the requirements which are described in the agreement are being met. It's important also to consider this approach in a stepwise way to build up the volume of plasma for fractionation in LMIC. So initially, it makes sense to use recovered plasma from whole blood, and this is important because this plasma is already available and could be wasted. While if it is of good quality, it can be used for fractionation. Concurrent plasma, which is a terminology used to define plasma obtained as a byproduct of platelet pheresis, can be used for fractionation. And when the needs are increasing, then plasmapheresis to collect dedicated plasma for fractionation can be considered, allowing to increase the volume of plasma for fractionation to cover the need in PDMPs. So the benefit of a contract plasma fractionation system are quite obvious. Access to a plasma fractionation facility without major capital investment. It's a relatively fast-track scenario to ensure product supply for patients in needs using the domestically available plasma. Again, a testing and learning phase on plasma fractionation requirement and fractionation technology, and this is important in case the country is considering to build in the future a domestic plasma fractionation technology. And this is important because plasma fractionation is quite complex. So this phase can serve as a ramp-up phase for domestic facility when the decision is made to go in that direction. The economical and clinical value of contract plasma fractionation are shown here. Economical value because plasma makes about 30 to 40% of the cost of PDMPs. So if unused recovered plasma of good quality can be used for fractionation, it's economically justified. Lower degree of exposure to regional or global shortages, as we have seen recently, provide some guarantee of supply for improved long-term strategic independence in plasma product supply. And this is also valuable because in many countries, recombinant product, biotech products, which are an alternative form of treatment of some pathologies, these products will not replace or are not expected to replace plasma-derived product in affordable ways in the foreseeable future. Now we reach to the next steps toward reaching the horizon, which is domestic industrial plasma fractionation. And then we certainly need to keep in mind that this technology of plasma fractionation is quite complex. It's simplified here on this scheme, where basically you can see that the technologies still in use for plasma fractionation are based on cryoprecipitation, combined with on the cryoprecipitate or cryopour plasma with different types of chromatography to isolate fragile coagulation factors, for instance, pre-purify the immunoglobulins, and you have the ethanol fractionation process, which is still used to prepare albumin, and also partially used in most plasma fractionation plants to isolate the immunoglobulin. And here you can see another example of a scheme of plasma fractionation with multiple chromatographic steps, and these processes combined with virus inactivation and removal steps. So the requirements for a domestic facility, as we said before, it's usually considered we should get at least 300,000 liters of plasma per year. Need to find a supplier of technology for getting this technology and training of local manpower. Important to get access to a skilled engineering companies knowledgeable about plasma product. Heavy capital investment, which is often underestimated, need to recruit and keep stable and skilled manpower, and government support and regulatory system should be in place. So these are the technical challenges which are faced when building a plasma fractionation facility. I don't think I have too much time to go into these details, but we can potentially discuss this later. So what we said, importance to have, we think, a supplier of technology which can provide all the SOP, regulatory files, validation files, clinical files, which helps the country to implement a domestic facility, and the importance of an engineering company knowledgeable in the field, and everything should be defined in the contract, which should be well written and detailed. So advantages of a domestic facility: strategic independence in PDMP, better control of the price of plasma-derived medicinal product, and it's also for some countries a way to get experience with the biotech industry. I think, as I said a little bit before, I think complementary means to secure safe plasma protein for all should be considered. The general director of WHO said that no one size fits all decision, so there is no silver bullet to try to reach the horizon in access to safe plasma protein. So this means that there is a way to consider combining the different approaches I have been describing here in order to try to reach the horizon in getting safe plasma proteins and PDMPs. So in conclusion, we all know that PDMPs are essential therapeutic products. We know that shortages of PDMPs exist at global levels, and they affect more particularly patients in low and middle income countries. Quality and safety criteria of plasma for further processing, plasma for fractionation, and of PDMP are very well understood in high-income countries and can be introduced gradually and monitored and regulated in low and middle-income countries. That's the way to reach the horizon. We believe at the GBA that stepwise mini pool, small pool processing is one approach which can be developed and introduced in low and middle income countries, in particular through South to South partnership, allowing to enhance the supply and prime local technology development, at the same time allowing to treat patients in need with a safer plasma protein. Contract fractionation in low and middle income countries by licensed plasma fractionators is a meaningful manner to improve PDMP supply without major capital investment. And it's a way also to test the rationale for domestic fractionation, a good means to give better access to products, improve the treatment of patients. And finally, international initiatives are the one we are conducted at GBS in line with WHO recommendation and guidance, together with ICSPP, which is the International Coalition for Safe Plasma Protein, can provide vital guidance and support countries to facilitate stepwise access to safe plasma proteins. And with these words of conclusion, I would like to thank you for your attention.
Thank you, Dr. Burnoff, for sharing your great experience and extensive knowledge. Any comments from the chairs?
Just want to thank Dr. Burnoff for such an elaborative presentation. I think no much clarification is needed, at least for me. Thank you.
Thank you, Doctor. We really got enlightened by your presentation. Thank you and your contribution.
Do we have any questions from our delegates? Thank you, Dr. Burnoff, for staying with us. Thank you so much.
You are very welcome. Pleasure to join your meeting. Very interesting. Thank you.
So now we are going to conclude our session with this wonderful talk. I would like to invite, first of all, CEO Indus Hospital and Health Network. Luckily, he is with us. And I invite Dr. Zafar Zaidi on stage to please present shields to our chairs. I invite Dr. Durinaz Jamal to receive shield from Dr. Zafar Zaidi. Our session co-chair, Dr. Aisha Junaid, please come forward to receive shield from Dr. Zafar Zaidi. We had one speaker with us. I think she's somewhere for the checkout. Dr. Nuzhat Mushahid, can anyone please receive shield on her behalf? And now it's my turn. So I have few important announcements. Those who are checking out today, please do so before proceeding towards lunch. We are going to have lunch break, but those who joined us later, please, I would like to remind that you have to fill the feedback forms, as these forms are mandatory to get e-certificates and CME credit hours. And another announcement is about guests who want to tag themselves on social media. Kindly do so, but hashtag TransFusion2023 should be there with your post. So I have another announcement. Before proceeding towards lunch, please try to visit, or I would encourage you to visit the exhibition area, as our sponsors put a lot of effort to arrange these stalls and innovations to showcase their work. So please move towards exhibition area, and then you can go to the dining hall from that way. After having lunch, we will resume here at 2:20, as we are already running a little bit late with our timelines. So please try to be on time, and we will resume here at 2:20. Thank you. Enjoy your meal. So try to wind up with your lunch in 30 minutes.
It is working. Welcome back, everyone. I hope you had a satisfying lunch and a chance to network and recharge. So we are running late, and we would like to really dive back into the program. We have an engaging lineup of speakers for our next session as well. And I think without further ado, I would like to invite the chairs. I am the moderator of this session. My name is Dr. Javeria Ijaz, and I've been heading the Department of Molecular Pathology at Indus for the last 3.5 years. But after my FCPS in 2008, I also had the privilege of working with GIZ, Safe Blood Transfusion Program from 2011 to 2014 before I went to the US for my PhD in human and molecular genetics. So it would be not very much off the mark if I say that blood transfusion was my first ever passion. And so it's my honor to be moderating this session at Transfusion 2023. I would first like to invite our esteemed chairs for this session, Professor Dr. Hassan Abbas and Brigadier Fahim Akhtar. Both of them need no introduction in the field of hematology and blood transfusion. Professor Dr. Hassan Abbas, his most recent achievement you are already aware of. He just received the Lifetime Achievement Award. But apart from that, he has had a very illustrious career. He has been he's been running the Safe Blood Transfusion Program ever since its inception, and also the Islamabad Blood Transfusion Authority. And Brigadier Dr. Fahim is the commandant of Armed Forces Institute of Transfusion. And he has also served the Army as a hematologist for the last 28 years. And so with that introduction, we will first continue with the presentations, but contrary to the program where we are having a question and answer session after every presentation, since we are running short of time, we'll keep the question and answers for the end of the session before we have a panel discussion. So our first speaker, it's an absolute honor for me to invite Miss Elaine Williamson. So you all just was introduced to her. She was also a recipient of the Lifetime Service Award in this conference. And she is currently the director of the Diagnostic Manufacturing Division at the American Red Cross USA, and has an extensive and impressive experience in the field of blood transfusion. And her expertise has also been recognized by professional organizations like AABB, where she is an abstract grader. And it is an absolute honor for me to now invite Miss Elaine Williamson for her talk on so the title of her talk is Unlocking Unlocking Compliance, Regulatory and Resource Requirements for Blood Bank Reagent Production. Thank you.
Hello, everyone. It's a pleasure to be here, and I'm very happy that the organizing committee invited me to come. And most of you know Dr. Saba, and you don't say no to her. So I got on a plane and came right away. So we're going to talk today about blood banking reagents. How many of you in the room, raise your hands, use blood banking reagents in your work? Many of you do. How many of you know how expensive they are? They're very expensive. So the Red Cross has a model where my little division is just 14 people. We manufacture blood banking reagents for the 44 reference laboratories that are in the Red Cross system. Because anything that we can manufacture and provide, they don't have to buy on the commercial market. So we save the Red Cross annually over $3 million just in reagent costs. And in the United States, after staffing costs, reagents in blood banks are the next highest cost. So you can scale up this approach. You can do it small locally, or you can scale up and distribute. So we're going to talk about today reagents that you would distribute, because once you distribute, then all the regulatory requirements come into force. Let me see if I can. this one? I don't know which one it is. Where do I hit? Can we do next slide? Okay, so I'm a medical technologist, like many of you in the room. I have a specialty in blood bank. It's a 2-year program in the United States, and I also have a master's degree in immunohematology. And so you're used to using the reagents on the end user point, but we're going to talk about what the manufacturer has to go through. It's the same knowledge, you just apply it in a different way. So there's many, as you know, diagnostic reagents. They're in vitro diagnostics. We're going to mainly talk about reagent red blood cells. And that's the term that the FDA uses in America for licensed or medical devices that are red blood cells. We're going to talk about the regulatory requirements, the resource requirements, which is your most challenging aspect, and then the validation, manufacture, and testing. So you have to remember you can do this on a small scale, or you can do it on a commercial scale. So we're going to focus on red cells, as I said today, and here's a list of the main commercial red cell products that you might encounter. Control cells, check cells, that checks the IAT, everybody knows about those. You also can get complement control cells, which can be made. Reverse grouping cells, everyone knows about those. Antibody detection screens and antibody identification panels. So we're going to focus today on the two lower ones, antibody detection screens and antibody identification panels. They are licensed by the FDA in the United States. So the regulatory requirements around blood banking reagents are all about their intended use, and it's a risk-based approach. So when you are using reagent red blood cells to diagnose a presence or absence of an antigen, like an antisera, or the presence or absence of an antibody in a patient or donor that's going to inform especially a transfusion decision, those reagents are licensed and require a biologics license application. They also have to be manufactured in an establishment, a manufacturing facility that has also been licensed by the FDA. Control cells, on the other hand, are controlling a test. So they're not doing patient testing per se. So those are called medical devices. And so it's less rigorous what you have to do to get them cleared to be able to ship them out across interstate lines. And again, it's a highly regulated industry, just like you saw with the plasma fractionation. The language I'm going to say is very familiar with what you just heard. The foundation of any good blood bank, transfusion service, or blood center is a good quality system, a QMS. And you have to have CGMPs, as you heard in the plasma fractionation. It's no different in this kind of manufacturing. You have to have design controls. And I'll go over very briefly that. It's if you take a product that you've never made before and you want to have it licensed, you must go through design controls. You must have document controls. I'm sure you all are well aware of those. Purchasing controls, meaning I get what I pay for and it has a specific specification before it's released for use in manufacturing. Identification and traceability of your lots. Production and process controls, these are key to a good quality system, whether you're making blood products or IVD products. Acceptance activity, that's in-process testing and quality control testing at the end. Non-conforming product protocols, what happens if you make a product that's non-conforming to your specifications? Corrective and preventive action, that's a good quality system. Labeling and packaging control, did you put the right label on the right thing? Did you put it in the right package? Does it have the right information on it? Handling, storage, distribution, and installation of equipment records, all of these things are required. Then specific to manufacturing world, we have certain documents that we must maintain. Design history file, that's if I design a product, I have to have a compilation of all my records of that I designed it. I didn't go out and steal it. That I have a device master record, it's my original records of how to make these products. Device history record, that is like a batch record. That is the record of how you made that specific lot. And of course, complaint files. So any manufacturer has to have a system. So if a customer runs into a problem, say you have a problem with an Immucor reagent, you can call or email Immucor and they must give you a number and trace the problem and give you a solution or an answer. No different here. Statistical techniques, your quality team must have, because you're making a lot of products, so you must have statistical techniques to take statistical samples so that you can, just like in quality control in a blood bank or blood center. So these are very, very common fundamentals that you would have as a manufacturer as well. Design controls are a special US FDA rule that came in the 1990s because several products went on the market and actually harmed their recipients or their end users. So they figured out there were problems in the design. So every part of the design process you go through, it's prescriptive in the FDA's CFR for user needs. You need to understand how the product's going to be used, where it's going to be used, what samples it's going to be used on, so that you know you can make the right product. You need to have design input. What does this product need to do? You have a design process that you're going to follow, design output to get a competent, efficacious medical device that actually people want to use. You don't want to make a device that no one wants to use. Everybody's familiar with this from an end user point of view, but imagine now that you want to make this. So you're going to have to find cells from donors, regular eligible donors who meet specific phenotypes. And in the United States, we have a very prescriptive requirement for what the antigram has to look like. It can be a 2 or 3 cell, it depends. Most common at home is a 3-cell screen, but what we have to do is have a homozygous expression. Anybody know why we want a homozygous expression? We want a homozygous expression because this is a detection panel and many antibodies show dosage. So if you have heterozygous expressions, you may miss an antibody that is present. So we have, by law, must have a screening device that has homozygous expression in certain blood groups, not in all of them. Same is with the antibody ID. We're going to have at least a 10-cell panel now, but you want to have it in a certain way so that you can identify your antibody, but more importantly, rule out the antibodies that are not present, because you want to be able to transfuse the appropriate unit, but you also don't want to spend a lot of time and money screening for antigens that you don't need to. So it's very, again, prescriptive of the FDA. So it has to be functional, meaning when the end user uses your panel, you need to make sure that a picture emerges of the possibilities of your antibodies. So if you can imagine, as a manufacturer, you have to find your donors, you have to plan the donation, and then plan manufacturing cycles around it. It's quite complex. Everybody's familiar with this. This is an example of an antibody panel. However, imagine if you had to find those donors. You had to get them drawn. You had to have 3 or 4 examples of each cell and then go into manufacturing cycles regularly, what the challenge that might be to continually be able to provide this product. So one thing that's often overlooked is the environment that the cells live in. So the red cell diluent and preservative is a product in and to itself. It has its own stability. It has its own manufacturing process because it matters how your cells live. So you always want to consistently manufacture this preservative, and you want to make sure that it retards hemolysis, that it keeps the cells alive so that the cell membranes stay intact, so that your antigens stay intact. So you'll have your own stability. You'll also have preservatives. The most common preservatives are neomycin sulfate and chloramphenicol. But some of the Europeans add gentamicin sulfate as well as amphotericin B at a very low concentration. Your cellular source material. This is an easy slide, but this is your real big challenge, is to find the cellular source material, the human resource that you need to be able to produce these consistently with the antigens that you have that are required. So they have to have, in the United States, we have to have 2 sources of antisera. So not just 2 companies, 2 sources. They can't have the same cell line if it's monoclonal, because you have to have very well characterized cells. Many companies have gone to genotyping their cells. So they have a full genotype, so they understand before it goes out on the market and is put against patient testing what their cells contain, highs and lows especially. They need to be DAT negative, of course, and you're going to have stability studies. Well, what's that? So you have to prove that your reagent is stable through expiration. So for cell products, we know they have a shorter expiration, so you You show stability for 3 days post-expiration as a manufacturer. So somebody using those cells to the day of expiration won't have any issues. They're still efficacious and will give the right answer. Approximately 1 unit of packed cells will provide about 5 liters of 2 to 4% suspension. That's good news, right? So you can use, depending on your cycle and how many vials you need to produce, 1 donor is often enough. You wouldn't want to pool donors for panels and screens. So manufacturing considerations, just like what we talked about. To summarize, your biggest challenge will be a stable and reliable supply of your O-pos and O-neg donors to fill out those antigrams every time, every month. Our team does a 28-day manufacturing cycle. So every 28 days, we have to have the cells in. The cells have to be less than 10 days old, because the expiration of your product is from the date of draw, not from the date of manufacture. You need a stable supply of all your other critical manufacturing supplies, from vials and droppers, clean room supplies, chemicals to make your diluent. All of that has to be on a reliable supply chain, has to come into quality control, then has to be released for use for manufacturing. So it's quite a not hard operation, it just takes a lot of logistical work. You need trained manufacturing staff. We're not doing patient testing, so you don't have to have an accreditation. You have to have a separate quality control unit. And why is it separate? You wouldn't want them reporting to the business head. They need to be reporting to the quality head so that they can stop manufacturing if something goes wrong with the product. So there are a lot of requirements to be a manufacturer of reagents in America. So you have to have a validated manufacturing space. What does that mean? That you understand your air and your water. So we have to monitor our air for viable particles every month in our manufacturing spaces. We also have to have a purified water plant and test the water monthly as well. We have a micro lab for testing water plates, air plates, and product. You have to establish your own limits. These are not sterile reagents. We consider them manufactured in a microbiologically controlled environment. So you constantly have to demonstrate that that's the environment that you're manufacturing in. You have to have a validated and certified clean room, validated manufacturing processes. You only have to do that once, but you have to show that you can mix a uniform bulk, that you can fill it, so that my first vial filled is the same exact one as my last vial filled. That's tricky in cells, because the diluent they live in, we call it happy juice, has a lot of sugar in it. And so the cells tend to settle very quickly. So if you have to fill 15 liters, you have to figure out a way to do that so that all vials are equal. All the equipment that you use in manufacturing has to have a maintenance schedule. You should already have that in your blood bank, so that's no different. And you recertify your heat treating equipment, your clean rooms every 6 months. You have a validated heat treatment for your vials and droppers. Again, not sterile, but you want to make sure that the vials that you're putting cells into especially are clean and you're not going to contaminate them there. And that you have a validated clean room disinfectant and cleaning process. Then you have to move on to your actual product. So how do I validate my product? Well, I'm going to do real-time stability. And what's that? That's when we take the cells that are already been filled in a vial, we turn it upside down. And we do that so that the product comes in contact with the dropper and container closure. So we show that there's no impact there, meaning that the product doesn't impact the container, so it starts leaking, or the container doesn't leach into my product and change it. Then you'll keep them on stability, testing at certain time points, certain tests to show that the reagents are stable. You're going to mimic in-use stability. So the average time cells are out on a bench could be 8 hours, 16 hours, 24 hours. So you have to do a survey with your end users, figure out the worst case scenario, and prove that your cells can withstand that. You do interference studies. As we know, patient samples can include icterus, lipemic, they can be hemolyzed, and plasma too, right? So can our cells be used with these kinds of samples? Otherwise, our labeling will have to say you can't do that. A sample agent type, what kind of samples can you use with your cells? Plasma, serum, both, one or the other. You have to prove all these things in validations. You're going to have to prove to the FDA that you can consistently manufacture these reagents. So you have 3 conformance lots that you turn into the FDA. Transport studies, if I'm going to ship these, so we make products in Washington, D.C., we ship them all the way to California. So I have to prove a validated shipping method so the cells arrive intact and will last through expiration. We do a national comparison study where we use outside laboratories and we compare our reagents, our new reagents, to a known licensed reagent, and we have to have 100% agreement in all testing. And then we have a vial and a dropper, everybody knows that, but you have to do certain studies to prove that you have an integrous system. So that's a fascinating study. So all the things, what we're doing is to make an efficacious product for patient testing that gets the right results every time if used as intended through expiration. Here's an example I just thought I would give of what it might look like if you wanted to manufacture a red cell product, any of them. You would start with QC acceptance of your red cells. So you'd have to know, they'd be known donors to you, they would be phenotyped when they're found, and then you would bring them into your manufacturing space and re-phenotype them again with a second source of antisera. They would be less than 10 days old. You want to always use fresh cells. You would retest each packed cell for its ABRH, DAT, and target antigens, whether it's A1 and B or whether it's K and KPB. You'd want to calculate the expiration date of your product, which is determined from your stability studies. And you start from the day of draw, not the day that you manufacture. You prepare all of your supplies to go into this manufacturing cycle. And what we do is we use sterile single-use products like bags and syringes so that we expose the product not to much air because that could contaminate it. And we have to be very gentle with the cells because you don't want to have artifact and hemolyze them while you're manufacturing. So what you want to do is just wash them up, and you're going to wash them in your happy juice and your diluent, because you want to start making them very happy, giving them the preservative already. But we're removing all excess protein, most namely the isohemagglutinins. And then we're going to test to ensure they're all gone, including a 3-cell screen, A1 and B cells. You're going to measure the hematocrit of your washed cells because that is how you're going to calculate your bulk. So as I said, you can turn one washed packed cells into 5 liters, but that's a 2 to 4% suspension. So you have to calculate that so you don't waste your resource. Then you're going to mix and test your bulk. It has to be 2 to 4% because that's what's on our labeling. That's the tricky bit. And then you're going to store it in your validated refrigerator. And then we're going to fill. What we do is we mix while we fill so that the cells don't have a chance to settle, so that all of our vials are equal from the first to the last. Quality control will then come in and take a statistical sample from the beginning, middle, and end of the fill, and they'll repeat all the testing that serology did, which was hematocrit, DAT, and color and appearance. They'll also do contamination testing to prove that our manufacturing process didn't introduce any bacteria. After QC release, we're going to label the vials. So the FDA labeling is a big deal for the FDA. So it includes the vial label itself, but it also includes your directions for use. That's considered labeling, as well as the antigen matrix that you're going to generate for your end users. Then we're going to package them. And at that time, you can do one of two things. You can either provide the actual physical paper, or you can have your customers go online and access the data they need. Quality control has the final say. They're going to do a final product inspection. They're also going to do an identity test. Is the right product in the right vial, and does it have the right label? That's sort of important, right? Then the quality verifies your antigen matrix because you have to make it up each time for each lot. You review the quality device. So all the time I've been manufacturing, I've been writing the history down of what I've been doing in my record. So quality, the department independently will review that record, and only they can release it for distribution. And then we have a validated shipping method, and we track the distribution of every vial. So for every lot, we must have a final disposition for every vial. And that, in short, is how you manufacture red cells. Here's one of our trays. It's in process. It's just been filled. So you can see it's an interesting kind of thing to do. It's all immunohematology. It's just a different application. So thank you for your kind attention.
Thank you, Ms. Elaine, for such an enlightening talk. We now invite our next esteemed speaker, Mr. Mustafa Mugaddam, who is the head of the Immunohematology Reference Laboratory at the Iranian Blood Transfusion Organization, and he brings a wealth of knowledge and expertise to us today through his presentation. His previous achievements include establishing the blood donor program at IBTO, as well as the cord blood program. And he's also part of various global initiatives at ISBT, being a member of the Working Party on Rare Blood Donors and Immunohematology. Thank you, sir.
Assalamu alaikum. Thank you for nice introduction. I thank the organizer of the meeting. This is the first time my trip to Pakistan, and so far I've been enjoying it among friends and colleagues. I thank Dr. Sabah Jamal and also Dr. Shabniz for inviting me to be here today. All right, rare blood donor program in Iran. Sorry. Any rare donor program has to be based on or an organization which is solid and already passed all the quality of an successful blood transfusion organization. An organization that can provide, routinely provides for over 99% of the blood products being used in the country or in the region. There is always 1% of the patients, they might have a special, difficult to be found blood type. So that's an extra effort one has to make, one organization has to make to provide that type of blood or product. So first, definitely the foundation of the organization has to be solid. As we can see in Iran, we've been, you've been so far familiar about it, is some indicators I want to show you and emphasize. First of all, as we discussed, 100% voluntary blood donation. Per capita blood donation is somewhere between 26, 24, almost 2.5% of the population who are supposed to donate, they are donating. Also, the 2 million collection per year, over 2 million collection per year. As you see, more than 51.5% are regular donors. So these are the indicators that you are doing fine and you are providing blood for a safe and sufficient blood for the general population. The numbers here show you the actually the infection rate for general population and donor population, 10 times less than for the HIV and 0.133 HPV, and shows the safety of blood pool among the donors and general population. So after the next step, once you have set up the whole organization and providing safe blood for, as I said, more than 99% of the population, for 1% of patient need or the group of the people is time to provide a first-class service. Rare donor program is for any organization or blood transplant organization is a first-class service provided to the patient and the physicians and also the, the group of people who have or are not a patient, but they might be a patient in the future. So in IBTO, there was an interest to have a good management for supply of very rare type of blood. And this is for the patients that have either antibody against a high frequency antigen or mixture of antibodies. And we needed to have a setup which could provide that blood locally and internationally. Once you have that, you can have outsource. If you don't have it in your local country or local area, then you can join a international group and ask for rare type of blood from international organizations. What would be needing to have that activity for rare blood program? You need to have a comprehensive system, and also you don't have to start from the scratch, but what you have, you can upgrade it and upgrade the donor activities and laboratory system to the level of acceptable standards. Here, the steps that is need to be taken, that would be education of the physician, nurses, the people that administer the blood, the education of the and awareness of your staff, and also the donors and so on. The standards has to be put for the rare donor program. Then collection SOPs, collection standards, the testing, which would be a little bit different or extra to what you have for the routine blood components, and component preparation, which is important, also storage and distribution. What we did in Iran, we tested for the beginning to create our own rare donor registry. For over 7 years, we typed over 50,000 blood samples, first-time donor, and for at least 18 antigens. For the beginning, we started from RH and KEL system, then we went to Duffy and KID, so on. We continued. This way, your expenses come down and you get to rare types sooner. So annually, we type 5,000 to 10,000 random donor samples. Every month, we tested blood samples, which was delivered from different provinces to central blood bank or central reference laboratory, and it was done uniquely in that laboratory. Also, we came along with the patient samples from blood bank laboratories that they had difficulty to have a compatible blood, and we tested them, and we come to the conclusion that they were identified as a rare blood group, having a rare blood group. So this added to our inventory, these people, as once they were patient, when they were in the hospital, later, once they are healthy, no problem, they become a donor for you. Also, other centers, infertility centers, thalassemia, patients, bone marrow transplant patient, they could add to the inventory of your registry, rare donor registry. So the phenotype, as I mentioned, it was done logically for all the blood samples. We used automation, manual, serology, and molecular method. And then once you have the donors, you have to retain them. So retention was done more aggressively compared to the regular blood donors. They were for their awareness, education, public relation. We created a national rare blood donor day, and we celebrated that day every annually on January 11th of each year. And then also we inform the donors that they are not supposed to go and donate routinely, but wait until we call them. At least you keep contact with them by calling them and encourage them to come and donate at least twice a year. Once, if you don't need that blood, you can always freeze them. So frozen blood department has to be developed, and then to keep the unit for the future use. Definition of a rare blood donor. There is no standard definition for a rare blood type or blood group. There are definitions that come, I have gathered here, that is said one which lacks a high frequency antigen like Cherano, Bombay phenotype, H antigen that everybody has on their in red blood, red blood, and also one with multiple common antigen, like thalassemia patient or sickle patient, when they become exposed to multiple transfusion of red blood cells, they develop antibody against at least 5 blood group system. So above 4 or 5 antigen negative red cell, if they have an antibody, then they become among the category of red blood type. It would be tough for them to find the blood. Low frequency antigen also could be called part of the rare blood group. Sometimes you can, like Lutheran A, Augustine A, and Kell, once you go further to the east of the geography, the Kell antigen become less, and that could be something that once exposed to the different transfusion for the patients, they develop blood, and you can see antibody among that population. So 1 in 1,000 or 1 in 5,000 are the blood groups. If you can find similar blood group among that population, that blood group can be put in a category of rare blood type. Currently, what we have out of 50,000, as I mentioned, blood donors phenotyping within 7 years, or right now above 10 years, we have 1,311 donors among our up to current date, our registry, rare donor registry. We have a frozen inventory of 313 in our rare blood donor program. 149 lacking high prevalence antigen. 55 of them are Bombay phenotype. Negative for multiple antigen are 151. Also, we have autologous rare donors. If somebody like has Bombay phenotype or any of the antigen like Celano phenotype, in advance before they need their blood, we draw the blood, we collect them and save them save them in the freezer. Also, we have a number of OPAS, ONIC, regular blood without being typed as emergency rules during the pandemic, like SARS, MERS, if the donors drop. So you have access to a good number of the OPAS, ONIC for emergency situation. So that could be part of your rare donor program. This year, we use 48 rare donor unit for our patients. As I mentioned, these are the machinery is automated, closed system, and for example, ACP 215 machine and freezers. We have about 12 freezers, which are the minus 80 Celsius, and each freezer depends about 40, 50 units, and you keep them for above 10 years. For education and awareness, we created certain items. First of all, rare donor awareness and recognition plaque explain rare donor complete name, specific, and it's given to the donor with the rare group, and also emphasizes that not only the donor knows about the information, but for emergency cases, a relative or a friend close to the donor knows about this information, all the information regarding blood group, rare blood type, and also a plaque or necklace, which is also carried, the donor carrying 24 hours with him with the blood type, and also a 24-hour national red donor telephone number that can be called, that number. If there is an accident and donor was injured and is not conscious, the number is there with the blood group, and then explain that they need to call to IBTO throughout the country, actually. And this has happened many times, at least many times, I mean like, maybe 2-3 times per year. The nurses or the people in the emergency room, they have called us and they have given us the name and number and of the patient or the injured, and we followed up, prepared the unit for and this necklace is fireproof, stainless, and also acid proof, and it doesn't get damaged. And they like it. They like this to carry them. Also, an ID card for red donor card with all the information is given to them so that they don't get, they keep their contact with us and vice versa. This card was provided to ISPT Rare Donor Program, and it through with the other countries, and it was used for country members. The table you see, as I said, these are very rare units of blood. Among those 1,313 registry rare donors, these are about 80 of them with this red blood type. OBAMBI donors, 29 donor we have. Total of OBAMBI blood type identified in Iran are about 59. But not all of them can donate. Some of them are young, Some of them are too old. Some of them are sick. They cannot donate. They cannot be a donor. But 29 of them could be donors. That's why it's included here. KPB is 3%, and which are relative, brother and sister. Lutheran A, Lutheran B, 8. And the population of Iran, as you know, is about 90 million. Out of those 50,000, we have this blood type, which shows the frequency of being this blood type to be found in the population. D-13, the rarest ever blood type is RH-null, which very rarely you meet this type of blood group. K-null, 2 people, and they have also donated for themselves. We freeze them, and we are being a member of ISPT Rare Donor Program. We are in the international ISPT registry our information, and if a country in a region needs it, last year we shipped a unit of K-null for a pregnant lady. K-null is here. From donor to Oman, Muscat, and she was pregnant. The fetus had a tough time and under distress, so the unit was transfused to the unit to the fetus. IUT was performed. The number of the patients who received last year, the total number of patients were 33, and they were thalassemia patient, liver transplant, labor and delivery, ALL, multiple myeloma, lymphoma, and total number of infused red blood cell red blood 184. Total number of frozen were so a liquid or frozen blood unit combination were used. ISPT, just 2 last slides. The ISPT Rare Donor Program, which Iran is a member of that group, was established in 1965. The headquarters is in Amsterdam, Netherlands, and the countries are Germany, Iran, Brazil, Canada, China, and you can see all these countries. And Iran is the only Muslim country which is member of the group, and the only so far country which is member of the group since 2010. And the ISPT Rare Donor Registry holds about 8,000 rare donors throughout the world, information throughout the world. Group picture of the immunohematology and rare donor members. And this is a review of 10 important steps to set up a successful rare donor program. That is first from the bottom of the pyramid situation. And if you want to set up a rare donor program, definitely situation analysis and priority setting, budgeting and administrative support important before you go ahead and start the rest of the deal. Immunohematology laboratory, a reference immunohematology, excellent immunohematology reference laboratory is a must, and that laboratory should have a liaison with international blood group reference laboratory in any international accepted certified laboratory, definitely to get their experience. And accessibility to rare high quality reagent, consumables, equipments, and special resources. interdepartmental communication and employee awareness, donors, staff, vice versa, promotion of excellent public relation exposure awareness, physical facility is important, and good environmental condition, engineering and equipment support to make sure that the freezers, equipments, they work and they don't fail, because you lose all your treasures. Otherwise, comprehensive information technology, packaging, and reliable national and international transportation. Packaging is important because your valuable product is going to be in the hand of a courier. And if you don't have a good packaging system, then sending the unit either frozen or liquid could be anything, any accident could happen and it's out of your control. So you need to have a definitely a packaging and reliable transportation system. Thank you very much for your attention. If there is any question, I'm available.
Thank you so much, sir. It is my privilege to invite our next esteemed speaker, Dr. Bushra Moez. Dr. Bushra Moez, she is currently the service line chair in the Department of Pathology and Laboratory Medicine at Aga Khan University, Karachi. And her remarkable journey encompasses many peer-reviewed publications and notable grants, awards, as well as the teaching of the next generation of hematology residents. So please join me in welcoming Dr. Bushra Moez. Thank you, madam.
Assalamu alaikum and good afternoon. Thank you, Javeria, for the kind introduction, and I'm really privileged and humbled to be here. Thank you, Dr. Sabah, for inviting me and giving this opportunity. I know post-lunch session and then too, the very last session is going to be too difficult. But I hope to be as light on your brains and your stomachs as possible. So may I have my slides, please? So the topic given to me was raising the bar, and it was all about the quality controls, something which is very close to my heart. I don't have any conflict of interest for this presentation. So I'm going to start on a happy note regarding the success which the national blood banking has seen over the last 2 decades. And I don't need to go over these reforms because these have been discussed many times during today. So I'll skip this and I'll move on to our own journey, because when Dr. Sabah asked me to talk about quality indicators, I thought I can share my own experience and perhaps the people can learn from each other, and I can also help in contributing in developing the quality indicators. If any blood bank is interested, they can contact me, and I can because we have gone through a long journey and we have seen how the things can be improved over a period of time. So the blood bank at AKU started in 1880, it was started in 1985. We have Hospital Transfusion Committee, known as Blood Utilization Committee, or BUC, right in the beginning. Then there were a number of accreditation. We started nucleic acid testing in 2011, and bacterial screening started in 2016. Then I will discuss this. Bedside ABO typing started in 2017, and computerized physician order entry started recently in 2018. So this is all about the quality which ABB says that starting right from organization and leadership going towards facilities, work environment, and safety. So there are a number of processes that are involved in quality, and those blood banks who are interested in developing quality indicators, they have to have something in each of these buckets. so that you can say that, for example, you have to do something for the customer, which are physicians, nurses, and patients. You have to do something with the technologist, because these are the one which are working in the blood bank. So for each of these buckets, you need to have certain quality controls. You have to have the indicators, you need to monitor them, discuss them, analyze them, and based on the benchmark, you can see your performance. So whether you are going up or down, the benchmarks, that's you are going to monitor on. You can do it on monthly basis, quarterly basis, or the way you want it to be. So at AKU, the organization and leadership is something like this, that we have the technologists, and among the technologists, we have quality officers and teaching and training officers. Teaching and training officers are supposed to look after the competency assessment of the technologist, and quality officers look after the measurement of all the data which comes. It's going to be handled by the quality officer, and analysis will be done by the blood bank manager and a hematologist. They are reported, there's departmental quality management committee, which is headed by the chair of the department. And in this committee, these indicators are regularly discussed, and the chair looks after whether the indicators are going in the right direction or not. So this is a monthly activity which goes on. And besides that, the blood utilization committee is a powerful committee. It's a hospital transfusion committee. There are members from each of the discipline, for example, surgery, medicine, OBGYN, cardiac anesthesia, etc. There's the chair, which is usually the hematologist who chairs this blood utilization committee, and they report directly to the CEO. So the hospital transfusion committee has a lot of powers to ensure that the things are moving in the right direction and the transfusion is being done correctly. So they report directly to CEO. And this happens, the problems are shared with the CEO on the monthly basis, but the annual reporting is done on the annual basis. So I'm showing you one of the planner for competency assessment. I think the most important resource in the lab is technologists, and they need to be monitored for their competency. We monitor the competency every year on the annual basis, but those who come, for example, after break, their competency is checked after 6 months, and the new one also goes after 6 months. And in the competency, the teaching coordinator, they make a plan for the entire year. So the technologists who are on particular benches, they are supposed to get the blinded samples, and they will perform the test. They don't know which blood group is there, whether the antibody screening is positive or not. They get the blinded samples by the teaching coordinator, they perform it and give their results. And then it is monitored whether they are able to give the correct results or not. And that competency is maintained for each and every technologist for all the analytes and all the testing which they are performing for that year, for the entire year. So how do we do monitoring and evaluation? We have to have internal, external assessment. Like by internal assessment is done by our own. We have a QC group, which does it on the basis on the 6 months on annual. And they come and see the records, documentation, labels, and everything, whether they're up to the mark or not. External assessment is done by, for example, AKU Blood Bank is accredited by College of American Pathologists. So they come after every 2 years and do an external assessment if we are performing up to the right mark or not. We monitor quality indicators. We look at the blood utilization assessment, proficiency testing, and we analyze the data. So I'll just briefly go through each of these so that you can have a taste of what we are doing and how many indicators we are monitoring. We are monitoring a lot many, but I'm going to show you some of them. So for example, starting from the quality indicators, pre-analytic, this I'm showing you 6 months data. We monitor how many samples are hemolyzed, clotted, or without barcode. That is, those samples which we receive in our blood bank, if they don't have the barcode, then the secondary label is need to be generated, and there's a chance of wrongly labeling the tube. So we are very afraid of the samples, getting the samples without barcode. And the benchmark for the hemolyzed samples is, for example, 2%. And without barcode is, for example, 0% for us. But you can see that a number of samples we have received in the lab, this indicates the total number of samples that are received in the lab, and these are the absolute number of the samples that were received without barcode. Then ABB does not require that we should be critically informing our patients or our physicians regarding some of the critical tests. But some of the tests like blood grouping for the patients who are admitted in ICU, and direct Coombs, for example, for newborn babies, for hemolytic disease of fetus and newborn, that is considered as critical by us. And they need to be reported for outpatients within 2 hours and for inpatients within 1 hour. And that's the target goal previously was 95%, and now it is increased to 99%, that every sample which you receive needs to be reported there and then. The orange bar indicated those samples that were reported in time. So you can see that a good number of samples, except for some outpatient samples, there was, like, for example, in April and May, there was some lacking behind, but usually the samples are reported within time. This is proficiency testing in 2023. Again, the results from Jan to June. And the blood bank is unique because for when you talk of the proficiency testing in other analytes and for other tests, the benchmark is 80%. But for blood bank, the results should be 100% correct. And that is something which is very unique to blood bank. And you can see that the results that were analyzed, that were received in the various months, the red bar indicate those that were acceptable, and the blue bar indicates those that were received by the lab for performing the test. So the results look pretty good. Regarding blood utilization, so this is how the blood utilization in 2022 looks like. And this is one thing I want to tell you here, that in our blood bank, we are responsible for providing blood to our own admitted patients. We don't send blood outside AKU. So all the blood that is collected, that is utilized within the hospital. And unlike what Dr. Sabha Jamal was showing, our main pool of donors is replacement donors. They are the friends and relatives that give blood for their patients who are admitted. And non-remunerated blood donor, autologous directed organization, they form a minimum less than 3% in total. So this is how the donor screening for infections looks like. If you look at the results, for the serological results, hepatitis C and hepatitis B are the topmost transfusion-transmitted infections, or TTIs, that are seen in the blood donors. And the same results are seen in the nucleic acid testing, that Hep B, Hep C virus, that predominates among the viral infection. So till now, I did not have a benchmark that what should I consider, like whether it's alarming that my blood donors are more seroreactive or NAT reactive than others, or what should I do about that? So I was looking at my past practices, and this is always we have been doing, that we are looking at our yearly seroreactivity for various viruses. And it has always been below 2% over last 5 years. And in fact, in the last 10 years also, it has always been below 2%. And for the NAT, it's always below 1%. So when I look at the seroreactivity for the viral TTIs, hepatitis B is slightly more than hepatitis C. And this is the seroreactivity results. And recently the paper has been published by Dr. Sabha. And I was looking at the data only for the Karachi donors because we are collecting blood from the Karachiites. So amazingly, the voluntary blood donors reported here 92% and replacement at 8%. And the results for the voluntary blood donors are much less compared to the replacement donors. So although I'm representing mainly the data from the replacement donors, but the results are as good as the voluntary blood donors reported here. So I was just wondering, I was listening to Dr. Sabha's presentation in the morning as well. I was just wondering whether the voluntary and replacement donors we are looking at, there's much more to it. For example, it may be the lifestyle, it may be the education of the donors, it may be the repeat donors that are coming in, the replacement donors. We need to look more at the data, and perhaps I need to do some mapping for these donors also, that from which part of the city they are coming from. Because apparently replacement donors that are coming to our lab, they have a healthy lifestyle, and their reactivity is, although they are replacement donors, is similar to what has been reported for the voluntary blood donors in this report. Transfusion reactions, we monitored this transfusion reaction because this is one of the dashboard indicator for the hospital. It is placed on our website and everybody can go and look at it. So the red bar indicate the total red blood product to all the blood products that were transfused over past 5 years. The red numbers indicate the severe, the mild reactions, and the black numbers indicate the severe reactions that were seen. So if we look at the detail, most of the reactions which we have reported in the past 5 years are febrile non-hemolytic transfusion reactions or allergic reactions. Very little TACO or TAT, they are reported in lesser frequency. So if I compare my data with SHORT, which is serious hazards of transfusion, these numbers indicate that what is one transfusion reaction per X number of patients. For example, according to SHORT, mild reaction, which consists of fever, allergic reactions, and hypertension, they are seen in 1 in over 7,000 patients. But what we are seeing is 1 in 75 to 600 patients, we are seeing 1 mild reaction. Similarly, TACO and HTR data is similar to what is reported by SHORT. But the pulmonary reactions, again, we are seeing a higher frequency of pulmonary reactions minus TACO. They are seen more frequently than what has been reported by the SHORT. So when we analyze this data, because we are using non-leukodepleted blood products, and perhaps that's why we are seeing more of the fever and allergic reactions. So this makes us a case that we should seriously think about using leukocyte-depleted filters universally, so that all our blood products should be deprived of white cells. Otherwise, we are going to see these reactions more often, and this number is increasing year by year. So analyzing this data, we should think of, and we should work towards leukodepleted blood products rather than providing blood products with white cells to the patients. We also monitor blood wastage. Now it looks like a very good number, but when we started back in 2016, it was above 11%, and it has been disciplined out because of various measures that were taken, and now wastage of the blood product has been reduced to 0%. The discussion about the blood utilization will not be complete if I don't talk about the cross-match transfusion ratio or the CT ratio in the elective surgeries. So when we looked at the CT ratio of the elective surgeries, it was really bad. And it was above 15% sometime back. So we engaged our surgeons What we did was we make a very simple Excel sheet for them, and we ask them to put their data into it. And this automatically tells them that whether the transfusion was required for that particular surgery or not. So this was their own data with which, because MSBS you cannot borrow from someone, you have to make it for your own hospital, looking into consideration your own surgeons, their own practices for transfusion, and their own patients. So when we did this, they come up with their own MSBUS. And for example, this one was for the general surgery, and they came to know that only for the right, for example, for hemicolectomy, they need one red cell unit, and for the rest of the other surgeries, they can go away with only by doing grouping and antibody screening for the patient. Similarly, for the gynae ops, they came to know that they can do, for majority of the surgeries, they don't require blood unit except for example, for myomectomy or some molar pregnancy. Otherwise, they can just group and screen their patient, and they don't require to cross-match the red cells for their patient, and the blood can be provided to them as and when needed by the blood bank if the antibody screen is negative. So what we did was we, because of the computerized physician order entry, this is how they put their blood products for each patient, that how many blood units are required for surgery. For example, in this case, they have, this is a patient who is undergoing elective CABG, and we inbuilt MSBUS in that so that they don't have to think that how many blood units are required according to MSBUS. This pops out by itself electronically. They know that now they have to, 2 units of red cells are required, for example, for elective CABG. They can overdo it if they want to, but this is what according to MSBS, the directory has been made. So despite all these efforts, we were not able to correct the cross-match transfusion ratio. The target was less than 2.5. And if you can look at over a period of years from 21 to 22, the CT ratio has always been on the higher side. We were unable to control it because it's not the blood bank that is controlling it, it's the clinicians and the surgeons who are doing it. So what we did was we looked at the CT ratio with respect to the surgery and with respect to the surgeon as well, that what is the CT ratio of each surgery. And we found that if we can control this, for example, for the neurosurgery, plastic surgery, and OBGYN, they are the one who are actually having a very high CT ratio. So if we want to control and bring the CT ratio in less than 2.5, what we need to do is to control the surgeons and to control the obstetrician, because they are the one who are cross-matching the blood, but they are not transfusing that to the patient. So that's why the CT ratio was very high with them. So something about process improvement. I'll go through this: audit, deviation reports, and complaints. So a number of audits were done, and these have also been published. So you can go through this if you are interested. The one which is recent one is platelet contamination. It is unpublished, so I just want to let you know about it, that what is being done. So this is how the workflow of bacterial culture for the random donor unit platelets. Majority of the work is done in the microbiology lab, that the sample is sent to microbiology where they culture the culture for us. And they do it twice actually, the initial on the first day and again on the 5th day. If the results are the same, it is considered as confirmed positive. It is negative right from the beginning, it is confirmed negative. But if you get a positive signal in Bactalert on the first day, which is negative on the final day, then it is considered to be indeterminate. And when we look at the results, this is again the result for the past 5 years. More than 84,000 blood platelets were checked for platelet contamination, and about 0.28% give a positive signal. And when we did the final culture, only 7 of them were positive, which indicates a very low rate, although the benchmark considered to be 0.51 per 1,000 in one of the meta-analysis, and we are looking at a very low culture rate. And these are the bacteria that have been identified from 2018 to 2022 in the platelet cultures. And a majority of the bacteria are actually the environmental bacteria that were introduced into the system when the testing was being done. So so these were the 7 patients. Actually, when the microbiology lab tells us that this product is positive, then we hold those platelets, we don't transfuse it to the patients, and those are discarded. But what happened that sometimes there's a need of platelet is so much that sometimes it is released even before the result of culture comes back. So these were the 7 patients in whom actually the platelets were transfused, which were contaminated with these organisms, but there was no mortality and there was no symptoms like febrile reaction. And perhaps I think the reason was many of these patients were already on antibiotics and were in ICU care. So that's why they did not show febrile reaction, although they did receive the contaminated platelet. And one of the reason, which if I go back to this number, which is very low contamination compared to what has been reported worldwide. I think the reason is we are culturing our platelets within 24 hours. And the FDA says that the platelet should be cultured within 36 to 48 hours, and that should be the platelet should be held for that period of time so that the bacteria multiply and increase in number before you are able to culture it. But because we cannot wait for that long for the platelet to be released because the demand is so high, we're culturing them within 24 hours. And perhaps that is the reason that we are seeing very low numbers. But then again, the platelets are dispensed also. Even if the platelets are contaminated, like for example, if we are missing within the 24 hours, we are releasing the platelets with those little bacteria perhaps to the patients where the immune system is going to remove those platelets, remove those bacteria from the system. So perhaps I think we are good in that way that we are culturing within 24 hours and the rate of bacterial contamination is low. So customer feedback, I think the complaints and the feedback which we receive from the patients, physicians, I look them as positively because they are the opportunities to improve. If you get a complaint regarding a product about any problem, then that is an opportunity to look back, analyze the data and see where you can improve your system. So we regularly monitor the complaints, incident, and suggestions, and these are the definitions which we use. So if you look at this, the total number of, the blue bar indicates the total number of feedback that were received from the physicians and patients. These indicate the valid complaints. Valid complaints by definition are those where the laboratory was found to be responsible for the particular mistake for which a complaint has been made by the physician or by the patient. So in Q1 to 3, 2023, we received 3 complaints, 3 suggestions, and we received some incidents also happen. And the most important for me is the wrong blood in the tube or wrong addressograph. And in this period, the total tests performed were, for example, 13,000 tests were performed in 3 wrong blood in the tube. And the ratio is that of every 4,000 blood tubes which we are receiving, one of them can be a wrong blood tube. This is what we are having which are seeing in our blood bank. But this is the benchmark that it should be. If it is less than, if you are receiving of every 1,000 samples, if you are having 1 wrong blood in the tube, then it's a very bad performance. So this has also improved over a period of time, and I will show you what we have done for it. And this wrong blood in the tube is actually in the blood bank. It's very, very serious because that means transfusion of the ABO incompatible blood product to the patient. Deviations. So there are certain there are certain activities which the technologists cannot perform without taking permission from the head of transfusion medicine. For example, release of an Rh positive cellular component to Rh negative recipient, giving a directed donation blood component, and the release of an blood product which is not completely screened, but that is an emergency. It requires to be dispensed to the patient. So that requires a permission from the hematologist to be given before the technologist can do that. And this is how it's maintained. For example, in this case, they were requiring a platelet which was not nucleic acid tested, but it was an emergency. So the hematologists look at it. Yes, there was an upper GI bleed, platelets were low, and they approved for deviation. So this is how the system works for the deviations, and the deviations are also monitored on the quarterly basis. Management of the non-conforming events. So this is what I was talking about, the wrong blood in the tube. So if you look at the number of blood products that were being given from 2010 to 2015, the wrong blood in the tube were continuously increasing. And if you look at the 2015, it was at height. And because of these wrong blood in the tube, there were at least 3 ABO incompatible transfusions that were made because the blood bank does not know that whether the blood in the tube actually belongs from that patient or not, because there's no way you can check it. It's on the face value. So what we did was, because we started bedside ABO typing back in 2016, and accordingly, with each red cells, this kit is issued to the patients. And at the bedside, the nurse is supposed to check the blood group of the patient. It's only the ABO blood group. And if the ABO blood group of the patient is similar to the blood unit which is released, then the nurse go ahead with the transfusion. Otherwise, they stop it and send it back to the blood bank. And you can see that from 2016 to 2018, the wrong blood in the tube has decreased significantly. That is, from 35, we have gone down to 15. And now we are also, for example, this is for 2023, we monitor how many kits have been released and how many tests have been done. Because after doing the test, the nurse has to put the test on the CPOE so that the blood bank can know that the test has been performed and the results are right. And these are also monitored so that we can know that whether if the nurse does not perform a bedside ABO, we would not know because we are in the blood bank. So they have to do it and they have to put it on the system so that we can see that in real time whether the test has been performed or not and whether the test has been done correctly or not. So the take home is quality assurance is a journey, not a destination. We all know that. The most important thing is if you want to improve the quality, if you want to build up the quality management system, you have to involve your leadership. Maybe the chair of the department, the CEO, hospital MD. Without their help, because they have to provide you with the financial support for all the good things you want to do. So it is very, very important that the leadership of the hospital and the blood bank should be engaged. And you have to make your case in order to get that financial support from the, and the most important aspect of all what you do is quality patient care. Because whatever you are doing, the ultimate gain is by the patient. Patient safety is your target. So whatever you do, you need to engage your leadership. You need to collect the data. It's a big data. You need to do analysis. And then you need to identify the benchmark and targets, and these should be analyzed on regular basis, that whether you are up to the mark or whether you are going down or up, where do you stand? All the stakeholders need to be involved right from the beginning till end. And it is very important to engage the technologists right from the beginning, because majority of the work will be done by them. And once you have done something good, celebrate the achievement and honor your working force. Thank you so much.
Thank you so much, Dr. Bushra. I would now like to invite any questions or comments from the chairs before we move on to the panel discussion. Sir.
Do you have any questions? You can proceed to the...
Okay, thank you so much. So moving on to the panel discussion. So the main objective of the panel discussion is to discuss the challenges and the way forward for the blood transfusion sector of Pakistan today. We have a group of panelists with a diverse experience. And now I would like to call upon the panelists, and I would request them to join the stage as I call them. So our first panelist is Dr. Hanif Mengal from the Regional Blood Center, Quetta. Who is currently serving as the professor of hematology and the head of pathology at Bolan Medical College in Quetta. And in addition to this, he's also the director of Safe Blood Transfusion Program in the region. Our next panelist is Dr. Amanullah Bhutto from the Regional Blood Center, Sakhar. And he is also a dedicated medical professional who has been contributing his expertise as a pathologist at the Regional Blood Center in Sakhar for the past several years. Dr. Noore Sabah, who is the director of the Regional Blood Center at Peshawar, and who also has several remarkable contributions in her field. Dr. Samra Waheed from the Regional Blood Center, Karachi, and she also has a lot of managerial and technical experience in the laboratory transfusion medicine as well as clinical hematology. Professor Dr. Shabnam Bashir from Allama Iqbal Medical College and Hospital Medical University. And she also leads the task force for revamping blood banks in Punjab and has served in the past as the director of the Punjab Thalassemia Prevention Program. Dr. Uzma Ataf, who is the head of the Regional Blood Center in Dow University of Health Sciences and has 10 years of discrete experience in the field of blood transfusion, 9.5 of which have been in Indus Hospital and Blood Center. And she played a key role in establishing and implementing all aspects of the blood bank operations, especially blood donor mobilization and collection. The next panelist is Dr. Agha Umar Daraz, who is the chief pathologist at Hosseini Hematology and Oncology Trust in Karachi. He's also the director of the Thalassemia Prevention Program in Sindh. And Dr. Aisha Junaid from Shifa International Hospital. Dr. Aisha Junaid is an accomplished medical professional with a strong background in diagnostic hematology, medical education, as well as clinical research. Thank you to all the esteemed panelists, and thank you for joining us on the stage. So Brigadier Akhtar has, I think he has a flight to take, and so we will continue with the panel discussion, but we would first like to present him with his shield. I would like to invite okay, Dr. Sabah Jamal to present the shield. So the format of the panel discussion is going to be in a way that we are going to first invite the our speakers to shed light on some topics one by one, and then if we have time, we'll move over to our delegates for any other questions that they might have. So my first question is to Dr. Hanif Mengal and Dr. Amanullah Bhutto. So we know that Pakistan is in the low human development index category, and this is an index that measures the health and education status of a country. But within Pakistan, there's also a lot of diversity among the different districts, and it is a misfortune that the northern Sindh and Balochistan are one of the lowest human development index within Pakistan as well. But at the same time, it is a fortune that we have regional blood centers in these two areas. So I would first like to invite Dr. Hanif Mengal to shed light on any particular challenges that he's facing in his regional blood center, Quetta, and then to Dr. Manula with the same question.
Bismillah ar-Rahman Rahim. As I'm running regional blood center, Quetta, and also dealing with the blood banks of all over Balochistan, we have a lot of problems. Regarding, first of all, I will say, as the topic indicates, roadblocks, there are many roadblocks in running centers of safe blood transfusion. And my personal experience is that we are getting many problems from our consultant sides. For example, if I am sitting in my blood bank, even in private blood bank, so or in hospital blood bank, we are receiving calls from our consultants. I need all blood, and please issue this unit or 1 or 2 units within 10 minutes. Is it possible to issue these units in 10 minutes? My reply is always, it takes more than 1 hour, 2 hours, you can wait. And what is their reply? They are more smart than us. They will say, no, do rapid testing. I will say, this is dangerous for patients, not good for patients. So always they are saying, this is not your concern. We are now going to save our patients. This is a big issue. Always they are not taking care of rational use of blood and blood components, especially in my setup. The consultants, they're always, when I am sitting in my center or in my blood bank, they're always using the term whole blood. So we have arranged many seminars for them. Dr. Hassan Abbas is there, Professor Osman Waid is there. They came to Quetta, they arranged seminars, we called them, and these people teach them about rational use of blood and blood components, but still the results are not promising.
Thank you so much, Dr. Hanif, for shedding light. And Dr. Manula, the same question to you. Before that, I have just a very small announcement. There's a working tea served, and so if any of you would like to have tea, you're most welcome to take it and bring it here.
Same way as Dr. Saab said that mostly in our area is also demanding by the doctors that please give us bags within a short time. So we try to understand to them that only in emergency cases we can provide the blood to you within 15 minutes. But other urgent cases take time 1 hour to 2 hours. In the same way, other problems which are most commonly, that is the, in our area, means demand is now so much increased, because initially when that RBC was started, average means budget process was according to 20,000s. But nowadays, as the currency rate is decreased and the value of the dollars increased, therefore, what happens, the patients' number is also more than 3 times increase. Therefore, we cannot solve their problems of the patient, that we can provide the proper rate according to demand. So in this way, need of increasing to budget, in this way we can solve the problem.
Thank you so much, Dr. Marala and Dr. Hanif. I think the conclusion here is that we see a common theme of a knowledge gap as well as a financial resource gap, especially because of the devaluation of the dollar and the lack of funds that are happening as a result. So we come to the next panelist, Dr. Nure Sabah, and so in Pakistan currently there are 15 regional blood centers that are operating, and if we broadly divide them, there are two different models. One is of a government directly implementing and providing services, and then there is a public-private partnership. And so which model do you think is better? And I think from my understanding, I think in Peshawar it is a direct service provision by the government. And what are the particular challenges that you are facing, and what do you think would be a better model out of the two?
Thank you, Javeria. Assalamu alaikum, everyone. First of all, I would like to thank Dr. Sabah Jamal and the Indus team for giving me this opportunity to share my experience and challenges. And I'm really delighted to see Dr. Hassan, the founder of the Safe Blood Transfusion, the one who initiated, and now that we are here, and obviously Indus and then government setups who has taken this whole process hand in hand, and it's benefiting Pakistan one way or another. Well, for your question, I have been asked this question multiple times, which system is better? It was a similar policy. It was one policy. The modus operandi is a bit different, keeping in view the government, rules, regulations, and the operations of private setups. I would say there are some benefits at government side because I myself am a government employee. But yes, at private setups, there are some edges that government employees cannot avail. For example, funding is an issue everywhere. Hospitals are facing issues. Blood banks, to bahut piche aate hain. We are at the end of the list. But Alhamdulillah, in KP, what we did, all the managers of RBCs united. We have 4 RBCs, Swat, Aptabad, DI Khan, and Peshawar. And we have sent united, together a proposal to the system, to finance minister and, chief minister and everyone. So they have agreed that the policy is going to be revised regarding the financials and administrative issues. So all these RBCs are working in a government setup. We are hoping that that will not be an issue after this. Another issue that we are facing is our RBC, or even all other RBCs in KP, were designed for 50,000 or 20,000, maybe 15 years back. Now that the population has tripled, how can we be expected to process 50,000 bags? Because, when we go and meet these administrators, they tell us, why are you collecting 70,000 blood bags? You are designed only to work for cater 50,000 bags. Hospitals are, we have 2-3 major hospitals, cardiology center and burn center, and we are facilitating them 100%. So this is also an issue that we need to expand the capacity of these centers, keeping in view their HR resources and everything. So yes, and another thing that we all managers, thank you for the platform again of KP. We had a meeting today in the morning again. We are planning to, the government is actually planning to have a united platform that will be working under a similar umbrella, maybe a directorate of blood transfusion systems. Blood transfusion authority is also going to be a part of that. So I believe working in a uniformity, a similar standard, it will improve things way better, because in Peshawar, for vendors, it is easier to provide services. But going to DI Khan is a big question. And they often don't even get to have a good competition among vendors. So yes, if we have a united platform for procurement and standards, so we can get better in that.
Thank you so much. So to summarize, I think, again, we have this recurring theme of resources and standardization, whether it's a public sector or a private-public partnership. And Dr. Samra, I will ask the same question to you, if you could also shed light on this.
Assalamu alaikum, everyone. Lately, I am talking about this issue everywhere I get the chance. Then when we will start working on patient blood management and hemovigilance, because I think these are the two under-discussed topics. Especially, I have been working in the government sector blood banks for past 3 years. I was just seeing Dr. Bushra's data, the transfusion reactions, the wrong samples, and I was just wondering that on what day we would be able to achieve these things. We are trying a lot, and in past 3 years, Regional Blood Center Karachi has around issued 100,000 products, and we are able to get only 55 transfusion reactions. And we actually got it after 1.5 years. And those who know me, they are asking me कि आपकी आवाज़ को क्या हो गया है? तो I am telling कि it has been permanently changed because of the regular awareness sessions to the hospital transfusion committee meetings, to the consultants, to the residents, because they don't know anything. So I believe the regional blood centers are working very good. The financial things and all have already been discussed. I believe that now patient blood management, I was reading an article जिसमें bundle patient blood management की बात हुई हुई है, not the individualized one. So I would say on the provincial levels and Dr. Sabha कि please कुछ ऐसे measures हों कि patient blood management और hemovigilance को भी centralized किया जाए, at least on the RBC levels, ताकि हम जाके MSS को, AMS को, physicians को दिखा सकें that you have to follow it. So this is my problem, and I hope
Thank
कि
you
इस
so
पे
much.
कुछ हो. Thank you.
Thank you, Dr. Samra, for this enlightening comment. So, Dr. Shabnam, I think you also bring a very unique experience to this forum. So, although you are not associated with any regional blood center currently, but from what I understand, there is a hospital blood bank which is operating. Plus, you have a very long and diverse experience with also the thalassemia prevention program. And you have been working in the public sector for a long time. So, what are the particular challenges that you face in the public sector with regard to safe blood transfusion? So, let's say if you plan to promote, promote the conversion of the hospital blood bank. So, what are the particular challenges that you would face in your setup?
Thank you very much for inviting me over.
Yeah.
So basically, the question that you put forward is very simple to answer because there are so many problems already highlighted in the public center hospitals. But on the other hand, I find it very ironical, the things that I've been witnessing here, right from the working of the Indus, its visit, and then talking about preparation of the, anti-seras and then hematology and everything. I think we belong to some other strata or some other planet while sitting here representing one of the largest province of the country, that is Punjab. And where I am stationed in Lahore, we are collecting like more than 200,000 units of blood per year. So it is a huge number. But the thing is that the things are not as they should be, and everything which is written in the guidelines that they should be like this in the blood transfusion service, right from the donor selection, donor safety, collection, preparation of the components, their judicious use of the blood products, they should be TTIF free, they should be cross-matched properly. There should be a very narrow cross-matched transfusion ratio. Nothing is happening in the public sector. So what I am trying to tell you here is for me in Punjab, except for the two setups which are being managed by the Indus, we have to start all over again. The total revamping is required of the system, taking into consideration that we have to somehow engage by hook or by crook the policymakers in any possible way so they come across to this notion that this is now important and high time to basically do the things they should be done. So for me, it is a very big challenge. I am not directly into it, but being a government servant and have a like good working relationship with the government, there are many ideas which came to me here during this conference that I'm going to put forward. And I am hoping that somebody listen to me. And in that context, I have requested President PSH are also taking the hint from Professor Sabha Jamal and director basically BTA Sindh.
that we should form and Brigadier Nuzat, obviously a pressure group sort of thing. It's high time that we come together and put it forward in a comprehensive, repetitive manner, so we get our message along to the authorities. We have to do it all over again in after doing a consensus among ourselves.
Thank you so
So
much,
with
Dr.
this,
Shubham.
I conclude it.
Thank you so much. So I think in addition to some of the issues that you have highlighted, you have also put a way forward, and which is an important, very important aspect, and that's engagement of the government and the politicians, and more needs to be done on that front. So with this, I come to the next panelist, Dr. Uzma Atta, who's also had we have had the privilege of working with her at Indus, and now she's establishing a blood center in a public sector university, Dow University of Health Sciences. And so this is also a unique experience, starting to establish a blood center in a public sector university. And so maybe you could shed light on some of your challenges and way forward.
Yes, thank you very much, Dr. Javeria. Talking about my challenges, there are like a big list of challenges I faced there. We were actually from the phase 2 of the SBTP program. So we were not that privileged to have a standalone building and that grandiosity we had in the phase 1. But still, I'm very thankful to Mr. Zayed Mahmood, who actually very much cooperated with us with the licensing and the equipment and everything. And whatever I have learned from Dr. Sabah Jamal, my mentor, my teacher, my supervisor, and I have a very deep regards for her. And whatever I am doing, whatever corrective action I made in that public sector, I give all the credit to her. That's because of her teachings and supervising that I'm able to make some changes at my position in the public sector. Talking about the challenges I'm facing, that it's right from the infrastructure. They have given me a small hall on the first day when I joined, and they said, now this is the place you have to upgrade it as a RVC. And then I came to realize they don't have a bleak idea that what is actually a regional blood center is all about. They are from the top management of the university, and they don't know about anything about the regional blood center, what it does, the idea behind it. So right from the infrastructure to the development of the standard operating procedure, the biggest problem which is still I'm facing is the attitude of the staff. Whenever I'm trying to change something, they're not actually, though they are very much educated, they are like they have double masters and everything, but they're not disciplined, which, like, I must say that the responsibility goes to the previous or whatever the management was there. So at least to regulate them to work properly, whatever time they are giving to their job, they should be 8 hours, they should be present over there. They're not doing it. Everyone is working on their own SOPs. There was no auditing actually. There were massive problems in the budgeting and costing, and the unit actually, which was like sold out on the cost, was not actually reflecting the actual cost incurring on the unit. So there were so many challenges. The biggest challenge at the moment is like we don't have the budget. We have approved the budget, and Dr. Durenaz Jamal, actually, she really cooperated with us a lot, but she actually managed to somehow get it approved, but we still didn't get the budget right now. So what we are managing in what we have right now, and we have almost escalated as a regional blood center, and like we are trying our best to do it, but the thing is that the challenges are there. The basic problem with us is that the attitude. We need to change the attitude of the public sector. They don't want to work, or if they want to work, they want to work in a very, they don't want to get out of their the comfort zone. The problem is that, and I feel I actually face a lot of resistance at that point in time.
Thank you so much, Dr. Uzma. And again, I think this is one of the recurring themes of engagement and education that keeps coming up in addition to financial challenges. So with this, I move to Dr. Aga Umar and Hussaini from Hussaini Blood Bank. And Hussaini is one of the organizations that was doing better quality work in blood banking sector even before this transformation with regional blood centers started. And so, Dr. Aga, I would like to ask you, what are the particular challenges that are faced by non-governmental organizations like yours in further improving quality standards and moving towards 100% voluntary donations?
First of all, thank you, Dr.
Sorry, I would like the audience to please, make some quiet for the panelists. Thank you.
Thank you, Dr. Saab. We appreciate the quality work of Hussaini. And first of all, I will also thank you, Dr. Saba Jamal, for inviting me here to explain the challenges. تو میں تو مجھے تو دونوں جگہوں کا تجربہ ہے. I worked in public blood banks, in government sector, in Sindh Healthcare Commission, and also currently I am working in Hussaini, جو private sector ہے. تو میں آپ کو ایک کمپریزن بتا دوں. 2006 میں منسٹر ہیلتھ جب فیصل صاحب ہوتے تھے, گبول صاحب, they ordered me to go to Thatta and Dadu to check the facilities of blood bank. Literally, I went there, اور یہ کوئی تقریباً 3 یا 4 دن کا ٹور تھا ہر ڈسٹرکٹ کا. And I trickled up to the تحصیل hospitals, district hospitals. ڈسٹرکٹ ہاسپٹل میں اول کچھ نہیں تھا, تو تحصیل میں جا کے دیکھا تو وہاں تو بالکل ہی میدان صاف تھا. اگر کوئی بلڈ گروپنگ کر بھی رہے تھے تو گروپ ٹو گروپ کر رہے تھے, کراس میچ کا کوئی کنسیپٹ نہیں تھا سلائن میں وہ کر کے. مطلب دونوں ہی ڈسٹرکٹس میں جو حالت تھی وہ بہت ہی بری تھی. Then I came and I give the report to Minister Health, and uske baad I have seen the changes. After in 2010, jab German help se Dr. Hassan Abbas Zahir Sahab ne jab ye project shuru kiya, to uske baad we have seen the lot of improvement in blood banking, especially in public mein bhi aur private mein bhi. Kyunki we have learned a lot from Dr. Hassan Abbas Zahir. اور وی یوز ٹو گو اسلام آباد اینڈ اٹینڈ دا میٹنگس. چیلنجز تو ڈاکٹر صاحب میں کہتا ہوں بلڈ بینک از اے A to Z چیلنج. آپ شروع کریں اس کو بلڈ ڈونر سے, تو سب سے پہلے تو آپ کو بلڈ ڈونر ڈھونڈنے میں اتنی دقت ہوتی ہے, جبکہ والنٹری آپ کہتے ہیں کہ 10%, میں تو کہتا ہوں کہ 1% بھی نہیں ہے والنٹری. یہ تو وہ گن پوائنٹ پہ جس طرح وہ کمانڈنگ آفیسر نے اپنا بلڈ دیا اور پھر سب کو کہا جا کے بلڈ دیں, اسی طرح وی آر گوئنگ ان فیکٹریز اینڈ ادر. تو HR والے آ کے وہ لیپ ٹاپ لے کے بیٹھ جاتے ہیں, اٹینڈنس لگاتے ہیں اور کہتے ہیں کہ جاؤ جا کے بلڈ دو, ادروائز تنخواہ نہیں ملے گی. دیس آر دا کمپلشن از ناٹ اے والنٹری بلڈ بینک, والنٹری ڈونر. تو والنٹری ڈونرس تو بیچارے کسی نہ کسی طرح, میں سمجھتا ہوں 98% جو ہیں ریپلیسمنٹ ہمارے ہاں ڈونر ہیں, وہ بھی زبردستی. اب تو اس طرح بھی ہے کہ وہ جو پروفیشنلس کو وہ اپنے فرینڈس اور رشتہ دار بنا کے لے آتے ہیں, اور وہ اس میں بھی ابھی تک وہ پروفیشنلزم گیا نہیں ہے کہ ہم کہتے ہیں کہ شاید وہ لوگ چلے گئے, لیکن ابھی اس کی مارکیٹنگ ہوتی ہے. لوگ ڈونرس کو پکڑ کے لاتے ہیں, پیسے دیتے ہیں, ان کو کوئی اپنا کوئی کزن بتاتا ہے, کوئی دوست بتاتا ہے, اور اس طرح وہ ان کو وہ بلڈ ڈونیشن لی جاتی ہے. تو وہ ایک تو یہ ہے. پھر جب بیچارے ڈونر بلیڈ کر لیتے ہیں تو پھر ہمیں آ جائیں ٹیسٹنگ پہ, اسکریننگ پہ. اسکریننگ میں جو ہمارے یہاں اسٹینڈرڈائز نہیں ہے, اب آپ ہمارے الحمدللہ حسینی میں 4-5 طرح کی مشینیں لگی ہوئی ہیں, اور ہر مشین اپنا ہی رزلٹ دیتی ہے. کوئی ریئیکٹیو دیتی ہے, کوئی بارڈر لائن دیتی ہے, کوئی نیگیٹو دیتی ہے. تو اس کا مطلب یہ ہے کہ اسٹینڈرڈائزیشن آف مشینس نہیں ہے, کٹوں کی کوئی اسپیسیفکیشن نہیں ہے. تو یہ چیزیں جو ہیں بڑی چیلنجز ہیں. آپ ایک جگہ بیٹھے ہوئے ہیں اور آپ کو 3 رزلٹ مل رہے ہیں, اب کہاں بھیجیں؟ اب ہم یہاں بھیجتے ہیں HIV فرض کریں, HIV ریفرنس رینج میں. ایکچولی سب سے بڑی زیادہ جو نیڈ ہے ڈاکٹر درے ناز, وہ ریفرنس لیبارٹریز کی ہے, چاہے وہ امیونو ہیمٹولوجی کی ریفرنس لیب ہو یا TTIs کے لیے. کوئی لیبارٹری ہمارے یہاں اسٹینڈرڈ کی نہیں ہے. فرض کریں ہم CLI پہ یا PCR پہ ایک ٹیسٹ کر کے HIV کو بھیجتے ہیں, تو وہاں وہ 2 ICT پہ اس کو نان ریئیکٹیو کر کے واپس کر دیتے ہیں. حالانکہ وہ آرکیٹیکٹ پہ, ایڈویا پہ اور بہترین مشینوں پہ وہ ریئیکٹیو ہوتا ہے, لیکن جب اس کو ریفرنس بھیجا جاتا ہے تو وہ, اس کے لیے میں یہ ریکویسٹ یہ ہے کہ ہماری جو ریفرنس رینج لیبارٹریز ہیں, دے شوڈ بی اپ گریڈڈ. जब मैं रेफरेंस लेबोरेटरी में था HIV में, तो वी यूज टू कंफर्म HIV केसेस विद वेस्टर्न ब्लॉट और PCR. अब अगर हम PCR टेस्टिंग और इलाजा या CMI के टेस्ट भेजते हैं तो वो ICT पे उसको नॉन रिएक्टिव करके और भेज देते हैं. मतलब दिस इज नॉट कोई खिदमत नहीं है. यू आर स्प्रेडिंग इन्फेक्शन. मतलब लीगली यू आर स्प्रेडिंग इन्फेक्शन. होना तो ये चाहिए था कि वहाँ जो लेबोरेटरी इतनी अच्छी हो कि जो हमने टेस्ट किए हैं उससे ज़्यादा अच्छा प्रिंसिपल और वो होना चाहिए. दूसरा ये कि अब जो डोनर रिएक्टिव आते हैं, हमारे हुसैनी यूज टू कॉल देम बैक एंड वी आर डूइंग काउंसलिंग विद देम एंड वी आर ब्रिंगिंग देम ऑन द ट्रीटमेंट ऑफ हेपेटाइटिस और B और C का. वो भी हमने विद द कोलैबोरेशन ऑफ एक NGO उसके कोलैबोरेशन से किया हुआ है. दूसरा ये कि अगर वो डोनर को अगर आप कहीं ट्रीटमेंट सेंटर भेज दो तो बेचारा पहुंच ही नहीं पाता. तो इससे मैं तो मेरी ये एक सजेशन भी है और एक आपसे दरख्वास्त भी है कि आप एक ट्रीटमेंट जो सेंटर है TTIs का एक अलहदा से ट्रीटमेंट सेंटर बनाएं जिसमें जो डोनर हैं, जो रिएक्टिव हैं या दूसरे पेशेंट हैं, वो जाएं और अपना आराम से ट्रीटमेंट कराएं. अगर लेबॉर्ट्रीज की तरफ से अगर कोई इस तरह का है तो उसी की बेहतरीन रेफरेंस लेबॉर्ट्रीज बनाए जाएं ताकि वो जाके आपको एक कंफर्मेशन हो जाए. तो मेरे ख्याल में चैलेंजेस तो बहुत हैं और जैसे डॉक्टर साहब ने बताया, हाल ये था कि जब मैं सिविल हॉस्पिटल की बात कर रहा हूँ, ये 2004 की बात कर रहा हूँ, मैंने लड़के से कहा ये सुबह कैबिज है, ये प्लेटलेट जाके इसको रखो, तो जाके फ्रीजर में रखा है. सुबह वो आया तो पता सब प्लेटलेट फ्रीज हुए हुए थे. तो सब कहने का मकसद ये थे कि एडुकेसी की जरूरत है, अवेयरनेस की जरूरत है. हमारे यहाँ आजकल HIV का तो बड़ा रेडियो में और मास मीडिया में आ रहा है, लेकिन ये ब्लड डोनेशन और वॉलेंट्री ब्लड डोनेशन की कोई कंप्लेन नहीं चलती, कोई उसकी एडवर्टाइजमेंट नहीं होती. तो जब तक हम मास मीडिया पे इसकी एडवर्टाइजमेंट नहीं करेंगे तो ना ही कोई NGO इसको कर सकती है और इंडिविजुअल लेवल पे कोई भी नहीं कर सकता. ओनली द गवर्नमेंट कैन डू इट. क्योंकि कितनी भी बड़ी कोई NGO होगी, अगर कोई उसको NGO को अगर कोई एड चलानी है टीवी पे या मास मीडिया पे, ही कैन नॉट अफोर्ड. तो ये गवर्नमेंट का काम है कि वो एडवर्टाइजमेंट करे और उसको जो है मास मीडिया पे उसको चलाए, लोगों को अवेयर करे, उनको बताए कि भाई ब्लड देने के क्या फायदे हैं, आए ब्लड दें. कुरान में भी लिखा है कि भाई एक जैसे आपने एक जान किसी की बचाई तो पूरी इंसानियत की जान बचाई. तो इस तरह की एडवर्टाइजमेंट होनी चाहिए. मैं समझता हूँ ये काफी मैंने कह दिया, कहने को तो बहुत सारी चीजें हैं, लेकिन मेरे ख्याल में इतना काफी है.
नहीं, बहुत जरूरी आपने इश्यूज हाईलाइट किए, स्पेशली ये कि आपने कम्युनिटी लेवल पे आपको क्या चैलेंजेस फेस करने पड़ते हैं, और दूसरा ये कि बहुत इंपॉर्टेंट आपने एक और रेफरेंस लेबोरेटरी की बात की टू प्रिवेंट TTI टेस्टिंग, बिकॉज दैट इज वन ऑफ द मेन challenges that we face in Pakistan. So I now come to Dr. Aisha Junaid, who has a very long experience in this field, and she also brings a unique perspective because Dr. Aisha Junaid is working in one of the few private sector organizations which is implementing standards in their true spirit. So Dr. Aisha, so maybe we would like to hear from you about the particular challenges of the private sector and yours being a sector that, a hospital that is still implementing its quality standards. And so what are the particular challenges that you face in a private sector organization with regard to blood transfusion?
Thank you. I think I have heard the public sector problems. Those are quite different from us. The quality journey has started long ago, but the biggest challenge I think private sector faces is the loss of trained manpower, because we do not have the bonding as the government sector has got a trained, the people we train, they go to the market getting the label that we have worked in a JCI accredited blood bank for 1 year, so they would get better jobs. So in one way that is good that you are spreading a trained workforce in your community, but retention of those trained manpower, as Busha has rightly said, that is the main backbone for maintaining the quality. So that is the biggest challenge because I face it every day. So that is one. The thing is, with my brothers and sister here, the challenges are opportunities and they provide us to improve the process. So yes, we face the same things with regard to, I think, one step would be the centralization and unity. We all have the problems, but if we have this vision that by 2025 we would have this goal achieved on the road of, or the path of quality, by 2027 we would have a national goal for that. We set targets for smaller time period rather than 10 years plan or 5 years plan. So if we work together as a national transfusion improvement force, and we set targets for 2 years, and then we sit together like this, public, private, everyone, and then we see how much goal achieved in 2 years. What were the factors which we couldn't achieve? How to surmount those factors? And then we set goals for another year or for another 2 years. Rather than making longer plans, then we have shifting of our policy makers and everyone. So this is, in my opinion, that we have got challenges, no matter, but at least reverse gear पे ना जाएं, आगे आगे चलते जाएं, तो शायद हम इंशाल्लाह अपनी मंजिल को पा लेंगे इंशाल्लाह.
थैंक यू सो मच. तो अगर हम इसको पैनलिस्ट की बात को कंक्लूड करें तो देयर हैव बीन मेनी एक्सीलेंट सजेशंस, लेकिन ये है कि जो हमारा रिकरिंग थीम है ऑफ एंगेजमेंट, पार्टिसिपेशन, यूनिटी, हार्मोनाइजेशन एंड स्टैंडर्ड्स वर सम ऑफ द थिंग्स दैट केप्ट रिकरिंग. फाइनेंशियल तो हमें पता ही है कि दैट इज ऑलवेज अ चैलेंज. सो सिंस वी आर रनिंग शॉर्ट ऑफ टाइम, आई वुड जस्ट लाइक टू invite maybe just a few questions, maybe 2 or 3 questions from the audience.
Thank you very much. When we started this project in 2010 to 13, first building construction started. The issues the speakers have mentioned about whole blood, and blood is required in 2 minutes or 10 minutes, and the screening issues. These issues, after creating this nice infrastructure, and it's put into the operationalization, and we have the same issues. I don't know. This is the one side. There are other private sector which is managed by Sindh and Punjab. Maybe some of the managers from the privately managed RBCs can share some light how they manage the whole blood, and this 2 minutes issues and 10 minutes you provide the blood. And the demand is of course increasing. The second part of this question, constantly we were asked by the government at various levels that which mode of apprentice is better. Is the private one and the public one? We are not sure which is the best one. And we also listen everyone, and we said, go and investigate yourself. My recommendation is maybe the PSH or the BTAs should come forward with some indicators which should say this RBC is our Aga Khan has done nice presentations. Take that indicators and apply on all the public and private sectors blood banks. There's huge debate on the costing of the private sector. Some people say it's very expensive, public is very cheap. We are unable to answer this as well in very high level policy making decisions. If someone can come up, or anyone, Professor Hassan is also sitting, these indicators for success of the RBCs universally, the costing pattern, the staffing pattern, then you will be able to know which center is better. So one is the indicator. Second, maybe not from you, maybe someone from the privately managed RBC. That's the question I refer to. Maybe Dr. Faiza from, yeah.
Now it's clear. So these were roadblocks. We were discussing the challenges, but the things I would like to say, the road buildings. The road buildings has been done by Safe to Blood Transfusion of Pakistan, EPOS, GIZ, and KFW. So what we have seen in our practical experience nowadays, after the development of RBCs, the things are more better than before. We are going, so we were not discussing that RBCs are very bad or things are very bad. things are very good, but there were some challenges. Now, after last time I said in my presentation that regional blood centers are blessings for the provinces, really blessings. I really salute Mr. Mark Gunther, Mr. Zahid Saab, Professor Sabah Jamal Saiba for arranging such kind of very informative sessions. And this session is also, I think, is the continuation of this safe blood transfusion program. We know the Indus network is performing very better. And inshallah, in future, we have one thing, especially in our centers, from our government sides, we are getting very minimum budget. You believe this year government of Assam kept 0 rupees for RBC. How can we run the RBCs? How can do we quality controls? How can we meet challenges? This is the difference between private sector.
Sorry, two of our
and
panelists
between
have to
the
leave because
public
they
sector.
have to catch their flights.
Actually, I
Dr.
want to
Shabnam
answer
and-
because he
Yeah,
asked
trying to
na.
get
I am from a regional blood center who is being managed by a public-private partnership, Fatmeed Foundation. So in the past 4 years, Regional Blood Center Karachi has not issued a single whole blood. We have never issued any whole blood, and it's not like if we don't get the demand, we get it, but we go to the doctors and we tell them कि हम whole blood issue नहीं करते हैं, उसके ये नुकसान आते हैं, अब मना हो चुका है और वो सब चीजें. तो सर ये इश्यूज अब हमारे नहीं है. हमारा CT रेशियो भी बहुत अच्छा है. इट इज बिटवीन 1.5 एंड 2. बट जो हमारे इश्यूज हैं वो जो मैंने कहा, हमें एक पेशेंट ब्लड मैनेजमेंट और हीमो विजिलेंस का नेशनल मॉडल चाहिए, जैसा कि अभी डॉक्टर बुशरा ने प्रेजेंट किया है. वो नेशनल मॉडल अगर हमें मिल जाएगा, PSH ही कुछ कर सकता है इसके लिए, किसी को रिस्पॉन्सिबल करके या तो कर दे, तो फिर हम उसको जाके इम्प्लीमेंट करवा सकेंगे. हमारा इशू है रिस्ट्रिक्टिव ट्रांसफ्यूजन स्ट्रैटेजी का. आई डोंट नो कितने हॉस्पिटल जो हैं वो करवा सकें अब तक इम्प्लीमेंट. हम नहीं करवा सकें रिस्ट्रिक्टिव ट्रांसफ्यूजन स्ट्रैटेजी. ये वाले इश्यूज नहीं है सर, RBCs ने बहुत कुछ बदल दिया है.
Thank you very much. I would like to extend a very heartfelt gratitude to all the panelists. So I think we can move on to the distribution of souvenirs because several of the delegates have flights to take. So I would like to invite Dr. Sabah Jamal and Professor Dr. Hassan Abbas to give the shield to the first panelist, Dr. Shabnam. Dr. Shabnam Bashir. Dr. Aisha Junaid. Thank you. Dr. Hanif Mengal. Thank you. Dr. Manala Bhutto. Dr. Noore Sabah. Dr. Samra Waheed. Noore Sabah, yes. Dr. Samra Waheed. Dr. Uzma Ata. And Dr. Aga Umar. I would now like to invite our speakers to receive their souvenirs as well. Miss Elaine. Mr. Mustafa. Dr. Bushra Moiz. Dr. Bushra. I will now like to request Dr. Sabah to present the souvenir to the chair of the session. Okay. And then I think there's one for the moderator. Thank you very much. And now I think it's time to acknowledge our worthy sponsors for this conference. So first I would like to call upon our platinum sponsors, Abbott. Is there anyone from Abbott? Muslim Trading Agencies and Hospicare Systems. And we are also very grateful to Mr. Masood for not only his sponsorship, but also his many, many hours of time in organizing this conference. And Dr. Adnan as well. Okay. ठीक है. Now our gold sponsors, Roche Diagnostics, Roche, and now our silver sponsors, Alpha Evolution, Sure Bio Diagnostics and Pharmaceuticals, S. Ijazuddin and Co., IBL Healthcare, Astro Life Sciences, Astro Life Sciences. S. Jazuddin and Astro Life Sciences. Lucky Lab, Hospital Supply Corporation. Lucky Lab. Hospital Supply Corporation. Mod Scientific. And Hura Pharma. हाँ, हाँ, नहीं बोल And Dr. Adnan for his massive organization that was happening all around and behind the scenes for this conference.
I have to really thank him. We have a small team, and if Dr. Adnan had not been there, this would not have been possible. It's been an undying support, and I have been bothering him, and Shabnis is his neighbor. So both of us have been the bane of his life. And he has tolerated 2 women, obsessive compulsive, very well. Thank you very much. It's really, should have a big applause for him. And particularly understanding blood transfusion when he's a chemical pathologist, but he understands TTI testing. Thank you very much.
Thank you. Now we have a small souvenir for our international speakers to be presented by Elaine. So now Dr. Durenaz Jamal would like to present us two souvenirs to our international speakers, Miss Elaine and Mr. Mustafa and Mehtab. So now it's time for a very small activity organized by IBL. There is going to be a lucky draw through which there are going to be 2 winners of cell phones, and they have requested Dr. Sabah Jamal to draw that lucky draw. Yeah. Yeah, we are going to find out.
शबनीश इधर तो आ जाओ ना 1 मिनट हाँ आ जाओ जल्दी से आ जाओ जवेरिया इधर आ जाओ उधर आ जाओ come on where is नीलम हाँ वो तो अभी बुला ही रही हूँ आपने देखा नहीं है वो चौड़े होकर बैठे हैं आ जाओ अब मॉडरेटर्स का तो होना जरूरी है अनीला जो कम एक पेज पे आओ Thank you.
And last but not the least, to acknowledge the hero of the event, Dr. Sabha के लिए, I think इन्होंने इससे छोटा गिफ्ट कभी भी नहीं मिला होगा. Dr. Sabha Jamal, SBTA की तरफ से बिल्कुल छोटा सा गिफ्ट, but it's a token of huge love from all of us to you.
It will be treasured and always good things come in small packages.
So, Dr. Sabha, you have to announce the winners. ठीक है वो अगर कोई ना हुआ तो अच्छा so one is Amir Ali, manager Indus Hospital and Network.
यकीन मानिए मुझे नहीं पता था इट्स नॉट अंधा बांटे रेवड़िया अपनों ही अपनों को इट वाज अ ब्लाइंड थिंग all the data that you see in all my presentations is comes from Amir Ali. He is a guru in data analysis and pivot tables and caters to all my requests. शबनी से तो तुम्हें आना पड़ेगा आ जाओ
The next winner is Samar Hayat Khan, a technologist, JDC Diagnostic Lab. If they have left, so we need to pick another one. They have left. Yeah, so now it's time to pick another one. So Sarfraz Ali Khwaja, manager. Manager admin RBCs. Thank you so much. Now I would like to invite Dr. Sabha for some concluding remarks.
Yeah, thank you very much for all the enthusiasm that all of you have shown. And yeah, along with depression, I always come up with, I have to have something to look forward to. And I think the time has come. Before I conclude that, I just want to thank my team, without whom this would not be possible, starting with Dr. Adnan Zubairi and A lot of things that I didn't even look into, even the organizing meeting. And I was sure that it would happen very well with him and Shabnis. And Shabnis has really worked tirelessly. It's literally hours and hours of work, and I really appreciate it. And I've promised her a whole week off from Wednesday. We have misused her completely. Thank you very much. And I have great hopes for my succession planning. Shabnis has been hired for my succession. And the more I see of her, the more I feel I'll be leaving this into good hands. Then we go moving on to Neelam, Javeria, both of them, Fatma. I didn't have the time to review anything, and I was like, just look at it, get it done. And it has been really a good journey and a happy moment that all of these youngsters are now so experienced. Makes me feel very old. But it's a happy moment that we can leave a battery of efficient people behind who you can rely on. Reliability is the most important thing. And then moving on to Omar, he organized the serology workshop very efficiently, and all our training team, Wajiha, Amjad, Amir Saeed, Rabia, tirelessly working. Thank you very much. This would not have been possible without an entire team. This was actually true teamwork, and I feel we can change things tremendously just with our own efforts. You know, we can't just keep on saying that so and so is not doing it. I think we'll need to get together some leads from all over Pakistan, create a small group. A lot of things are possible when the people unite. Big revolutions have been put forth. After years of working, I've come to the conclusion we'll have to take our destiny. हमें अपनी किस्मत अपने हाथ में लेनी होगी. बहुत हो गया ये कहते हुए फला नहीं करता और फला नहीं करता. हमें baby steps which can be very baby, but a lot of things can be done. It's not all hopeless. With seeing so many people available at the ending, which has been a long day, I have lots of hopes, and I think Dr. Bushra, Baki sab log, Aisha, and everybody, I think we'll create a group within 2 to 3 weeks, start coming up with things. A lot of things can be implemented ourselves. Working together, हर चीज में पैसा नहीं चाहिए. You don't need money for everything. A lot of things can be implemented, and then you do need money for certain things where we can think of innovative ideas in your own regions. Indus team is a guru in fundraising, so let's utilize that guruness. And Zahid, I was discussing with him, was saying, I have some ideas, and I have a lot of ideas now, because actually I'm just tired of thinking somebody else will do it. No, we'll do it ourselves. So let's stay in touch and do it. Thank you very much. The blood transfusion community needs to come together. Thank you very much for all of you to be here. Thank you. Javeria, we need to have a picture. Ajo. Dr. Adnan dena hoga.